large pupil, then it projects a very distorted image on the retina and results in a very poor visual acuity. Now, how the pupil alteration changes the corneal wavefront. Now, you can see this in this video, that you just see that RMS value is around 11.94 at 7 millimeter pupil size. But if we decrease the pupil size, you can see the transformation that is happening to the corneal wavefront, which is going through the pupil. Now, this is at 4, this is at 3, and this is at 2 millimeters. So the corneal wavefront becomes whichever is passing through the pupil. If you make a size of the pupil, say from 7 to 2 millimeter, the corneal wavefront is quite regular, and it will project a less distorted image or a better image on the retina, and the visual acuity will improve. Now, same in terms of visual simulation. You can see the ETDRS chart, and if you are altering the pupil size for the same corneal wavefront, you can see the point spread function down below. If it is closer to 1, it's better. So from 0.02, it has improved significantly to around 0.2, and also the visual simulation. This is done preoperatively. And keeping this in mind, now let's go ahead with the pupilloplasty in this patient. So this is a patient. You can see the RMS value 11.94 and higher order values around 8.62. Normal values are just 0.2 to 0.3. And these are the point spread function and simulated visual acuity. So we go ahead and do a pupilloplasty in this patient. So this patient also had, the lens had some deposits, so we also exchanged the lens in addition. So by cutting that into half, then by twisting, taking it out through the bone, multi-piece in the sulcus, and then doing a single pass 4 through. As all of you are aware that from one side you just pass the 10-0 Prolene straight needle, and from the other side you pass 26 gauge needle, you thread it, and then you take it out from the one port, and this is out from this port. Now you pull out the first loop between through that. So that is a typical single pass 4 through pupilloplasty. And once you have done it, you just pull the two sides from the outside. And you can pass 2 or 3 sutures, whatever is amount needed to make the pupil of a desired size. So here we used 2 single pass 4 through sutures. Similar procedure is repeated on the other side. And the pupil size, which was around 7 millimeter, we have converted that into 2 millimeter. So this is the post-operative wavefront. So pupil size is 2.5. The RMS value from 11 has come down to 0.75. Normal is around 0.3. It's much closer to that. Higher order aberrations have also decreased, and this is a visual simulation and point spread function which have improved. This is the pre-op visual acuity was 160, it improved to 618. Also, some part was contributed by exchange of IOL in this patient. This is another patient. The pupil is slightly irregular. Now here the RMS value is around 3.09 for the wavefront error, and higher orders are 2.2. So this is a visual simulation. The pupil size is around 5. When we when we thought that what will be the wavefront analysis with a 2 millimeter pupil, so this is what it was coming out. The RMS would be around 0.4 and higher orders around 0.25 and visual simulation. So we went ahead and did a single pass 4 through. One suture was required in this. Now there was iridocorneal adhesions. They were removed. And after removing the iridocorneal adhesions, then we passed single suture. So another advantage is if there are iridocorneal adhesions, they will not reform after you have done a single pass 4 through pupilloplasty, and also the angle will be much more clearer, and it will drain beautifully after the surgery, decreasing the chances of post penetrating keratoplastic glaucomas. So this is the pre-operative and post-operative picture. From 660, the vision has improved to 612, and you can see the pre-operative and the post-operative optical quality summary in this patient. This is my last video. So in this, actually, rather than doing a pre-operative analysis of the wavefront, this was a triple procedure that we did. But along with that, we did a open sky pupilloplasty in this. The pupil was highly irregular. So the same we passed 2 sutures. So and completed the penetrating keratoplasty. So this is after penetrating keratoplasty. This is the wavefront if we keep the pupil size as 7, and this is the wavefront to the pupil size that we had reduced it to 2 millimeter. So there is a marked difference in the regularity of wavefront which goes through a small pupil. And with this I would like to summarize that it's good that it gives actually ophthalmologists a preoperative tool to assess that how much visual acuity the patient is likely to improve, and you can take help of corneal wavefront guided pupilloplasty in such cases. Thank you.
Thank you so much, Dr. Vijay, for nicely demonstrating how one can take vision further for these difficult cases. I'd like to now invite Dr. Chintan Malhotra, who's going to tell us about transepithelial cross-linking for corneal ectasia, the road less taken.
So thank you, ma'am, and a very good morning to all. I'll be speaking about transepithelial CXL, something which not many people do and not many people believe in, and just try to take you through a journey which we're just going through to see whether it's worth the effort or not. So Epi of CXL has been a loyal friend for a long, long time because it's shown greater than 90% efficacy in preventing progression of keratoconus and is a safe procedure. So then why shift from epi off to epi on? That is the epi on being the transepithelial CXL. One, because there's less post-operative pain. We haven't removed the epithelium. There's reduced risk of infectious keratitis. And the third, which bothers me sometimes a lot, which you cannot control, is the stromal haze, which one sees with the epi off procedures. Occasionally one does see. And also then you have the early return to contact lens wear. But however, transepithelial CXL did not have great beginnings, because epi of CXL was shown to increase the biomechanical strength by around 320% as compared to baseline and have demarcation line at approximately a 300 micron depth. On the other hand, transepithelial showed an increase of biomechanical strength only 1/5 that of the epi off procedure, and it was shown to have shallower demarcation lines. That was in the beginning, somewhere around 2008, 2009. And so there was this kind of stamp of uncertainty that is this a procedure which works? And are we doing right by our patients if we are doing this? This slide, I personally hate the slides, but I always show this because it just shows you that how confusing literature, I mean everybody else, is about the results of transepithelial CXL. The studies highlighted in blue show that it is effective, equally efficacious at least. The studies in red show that it is less effective. If I were to summarize my understanding of these studies, it would be that epi off CXL causes a greater flattening of the keratometry, but many studies also report an equal efficacy of epi on versus epi off. But what also is important is that transepithelial was more frequently associated with better visual outcomes and a greater visual comfort in large number of studies. And so when you are looking for something you want to do, you try to find evidence.
Compress the intraarticular pressure with a capsulotomy needle. I use a needle a lot. You can start with the mini rhexis. What do you mean with a mini rhexis? You can either do a small rhexis, about 3 to 4 millimeter in size. If you are comfortable with the phacoemulsification, do the phacoemulsification, and then you can enlarge the rhexis. So you can see in this case you have to be very careful. Only the center part of the intraarticular pressure is decompressed, but at the mid-perineum with the help of anti-YAG laser capsulotomy or a slow and guided decompression of the raised intraarticular pressure with a 24 gauge needle mounted on a 2 cc syringe. So this is what I wanted to say, and again it's a small appeal and a request from my side. I'm contesting for the post of member scientific committee in the coming AIS election. I've been in the AIS since last 6 years. I'm doing great work, I feel, academically. That's what the feedback I get from my people. So request you once again for your support. Thanks a lot.
Thank you so much, Dr. Amit. So actually, it's been a really wonderful session. All the speakers were here and had taken great efforts in preparing their talks. And I would also like to, thank my co-chairpersons for the time that they spent and their valuable comments, and the audiovisual staff and the timekeeper. Thanks to everyone. And the audience, we have a quick group photograph, please. We'll invite all speakers to come.
So we would like to extend a heartfelt gratitude to our chairpersons, Dr. Radhika Tandon, Dr. Tushar Agrawal, Dr. M. Vanati, and Dr. Nupur Gupta, along with our Dr. Anu Malik and Dr. Amit Porwal, along with our moderator, Dr. Naivete Lomi, and all our wonderful speakers. And thank you very much, all the speakers, for being in time, and also our chairpersons and moderator for helping us with that. Wonderfully, we have covered this first session of day 2 at RPC Ophthalmic Carnival 2023. Moving on to our next session, may I acknowledge the presence of the chairpersons, if they are here. Dr. M. Vanati, Dr. Jasbir Kaur, Dr. Rajesh Sinha, is he there with us? Dr. Rajesh Sinha, Dr. Rupal Shah, okay. Dr. Ashok Sharma, Dr. Amit Porwal is already here with us, and the moderator, Dr. Prafulla Maharana, is he here with us?
Our clinic, and which will be the true personalized medicine approach for dry eye patients, keratoconus patients, patients with diabetic retinopathies, ARMDs, multiple such things. And it's just not going to be diagnostics, but a combination of both of them. Now, why biomarkers? Because biomarkers do help in identifying that which marker is higher or lower, and it will help us to have a targeted treatment. So what is the ideal biomarker? It should be like rapidly, it should give us the results. It should be done with ease of operation. It should be non-invasive first thing, and multiple analyses should be there. And we should be able to quantify on whether these biomarkers are on the higher side, lower side, whether when we treat the patient, whether the biomarkers are responding to the treatments, and whether it's coming low or not. So the question here is, could just the tear film, the tear fluid assessment be the answer here? The answer is yes, it can be the one, and it will help us in quantitative analysis. It will address the discordance between the signs and symptoms. It will address the, it will help us do a specific targeted therapy and also precede clinical manifestation. So at this point of time, what we do is the Schirmer strip where we do the dry eye test, the Schirmer's one. Rather than just discarding it, we collect this in an Eppendorf tube. And after we have collected them in an Eppendorf tube, we rather than just discarding it, we collect this in an Eppendorf tube. And after we have collected them in an Eppendorf tube, we load it in a cartridge. And then it's just a very simple test. The Schirmer strip is collected after 5 minutes, and it's put in an Eppendorf tube. The Eppendorf tube is shaken for 5 minutes. This is just done in clinics. You don't need to go to the lab. You shake it for 5 minutes with a buffer and take the analyte and put it in a cartridge. And at the end of it, it will tell you that which of these biomarkers are on the higher side or lower side. And at this point of time, we have chosen MMP9, IL-6, IL-1 beta, IL-10, VEGF-A, TNF-alpha, IL-17, and ICAM-1. So all these biomarkers, for each of these biomarkers, it will tell you whether it's in the normal range, whether it's on the higher borderline range, or whether it's on the higher range. And there is an AI scoring which is incorporated, so it will not be just one center data or it's just not going to be like a normative data range set by one person. According to the data collected from multiple centers, it will tell us about the biomarkers rate. Now, why did we choose these biomarkers is because these biomarkers have a lot of role in not just dry eye, but other ocular surface inflammations, keratoconus, your DLKs, sterile infiltrates, and post-refractive surgery or cross-linking haze. It has also role in your Sjogren's disease, and it has also got, apart from corneal and ocular surface conditions, it can be used for your retinal conditions. ICAM1 and VEGF and IL-17 play a very major role in diabetic retinopathies and ARMDs. So these biomarkers are not just chosen from one disease perspective, but from multiple disease perspective, and this is what we are looking at. So now what do is, we do the tear test. It takes 90 minutes for the test results to come. And once we have these results, we see what is the level of these biomarkers. We identify the causative factor, and we then target the therapy. And the beauty of this kit at this point of time is that each of this drug has a treatment. For example, if the MMP9s are on the higher side, you can give cyclosporin and trehalose-based drops. But along with MMP9, if ICAM also is on the higher side, India now is coming up with its own lifitegrast-based drops, which will be launched in next 1 or 2 months. So you can give that. If IL-17 or IL-6 is on the higher side, you can give iLite or a steroid-based therapy. And then based on like MMP9 levels are like 3 or 4-fold higher, you can add a procedural therapy like a LipiFlow or a LipiFlow plus any IPL-based therapy, and then you can monitor them. So these biomarkers, like traditionally you'll just give a lubricating drop. If not, you'll add a cyclosporin. If not, and you'll see hot fermentation. If it's responding, you'll add LipiFlow and an IPL-based therapy. But this kit will actually help you that at the first sitting only you do the test, and it will tell you what procedure to give, so it will lead to a less economical burden on the patient, and it will also have a happy patient and a happy doctor. So quickly this case, how we are using this in our practice. This is a patient who is post-LASIK 2 years, has always been the OSDI, the tear film metrics are on the normal side, but the OSDI, the discomfort is extremely on the higher side. I'll just take a minute. And all the drops he's used in the world. So when we did the test, we saw that cyclosporin, which works on MMP9, apart from that, IL-10 and IL-1 beta are also on the higher side. So based on the published work, we did only IPL therapy for him for 3 sittings. And you can just see with 3 sittings how nicely his biomarkers have come on the lower side and how happy he is. So this treatment will just help us to monitor the treatment outcomes, stratify what should be given, the quantity of the treatment should be given, and the right treatment what should be given to the patient. Thank you.
Thank you, Dr. Pooja, for such a wonderful talk and integrating both the things, like from the lab to the clinic. You have very well presented the things.
Thank you, ma'am.
Now I'll welcome Dr. Sujit to give a talk on
Pooja,
current
do you find
investigations
that,
for evaluation of dry eye.
Sir,
Sir,
can
please.
Pooja, did you find any correlation, clinical correlation with the values improving and the symptoms also improving?
Yes, so the OSDI scoring in that patient because of the lack of time was 70, in spite of using cyclosporin and other drops. So what we saw was the OSDI scoring from 70 came down to around 20, which is within acceptable range. So we are doing tear film metrics along with OSDI scoring and along with biomarkers. So
And is this available
so
commercially?
it will, now the regulations are changing. So we don't know how much. From our side, we have all the data which has been applied to the DCGI, but how much time they will take, we don't know. Once it's approved, it will be available to all.
Thank you.
Thank you.
But
Biomarkers available at any, all your patients are subjected to biomarkers?
Yes, sir. So we subjected all our patients to that, and not just the ocular surface. The retinal team is also doing work on diabetic retinopathy and ARMD because we wanted normative data and the disease-based data. So it's done for all patients. Thank
But
you.
as for the kids are concerned, like if it is not been, but you can customize the kits. Like
Absolutely.
whatever the
Yes,
things,
Yes,
so
yes,
that
ma'am.
is the
yes.
best.
UP have a lot
Yes.
of
Yeah.
multiplex ELISAs, and you could customize these kits.
yeah.
And again, I think we have done a lot of work and published on inflammatory markers. We did it in, of course, in ocular GVHD patients,
Yeah,
and
I've
we
seen that
did
also.
find a lot of variability, and we did a whole gamut of biomarkers. So that is where the gray zone is. And as all of us who are managing cornea and ocular surface with significant dry eye patients, we do know that putting your patient on a LipiFlow straight away is not going to
Not-
give you
yes,
results until and unless you're going to medically control the inflammatory mediators, bring them to a lowest possible level, and then put them on any of these newer modalities. That's when it's really going to work.
Yeah,
Yeah,
so
but I
this
think
is- yeah.
it's still evolving,
Yeah.
and perhaps we have a long way to go before we
A
could
very
really
long way.
pinpoint and say which tier biomarker is really going to be of particular value.
Yes, ma'am,
Yeah?
truly, sir.
Sure.
Thank you.
Thank you.
A very good morning. I thank my RPC teachers for giving me this opportunity. Basically, my talk is not a very cutting-edge technology. It's just a reminder of how to approach an investigation for the dry eye, the current protocols. So as we all know, it's a very common problem in our ophthalmic OPD and a huge economic burden, and it's a very disturbing thing in social life as well as the quality of life as far as the patient is concerned. And the dry eye definition is keeping on evolving, it's keeping on changing, and what we are using now is the DUCE-DUE classification and the definition as per 2017. And we all know it's a multifactorial disease where there is loss of homeostasis of the ocular surface as well as the tear film due to multiple reasons that is stated here. And they have come up with a clinical decision algorithm in which they have given much importance to the symptoms as well. So we are dealing with patients who are asymptomatic with signs as well as symptom with no signs. So what guides us in investigation? We very well know that the symptoms and the signs don't match in dry eye. So there is no single gold standard investigation that is helping us to find out if a patient is having a dry eye or classify him. So there are an efficacious battery of tests that's available, but how to use it and how appropriately and standardized way you have to use it is what the DUCE-DUE classification or definition is trying to help us. By end of this, we have to know like whether the dry eye exists or not, of what severity is the disease, and what type, and what is the underlying etiopathogenesis. So this is the dry eye diagnostic approach that has been put forward by the DUCE-DUE. If you look at it, there are actually three parts. The first part is actually the triaging of the patients and the risk factor analysis. The second part comes the diagnostic test, which actually diagnose the dry eye. And the third part comes the subtype classification of the disease. Triaging questions, normally there are maybe diseases that may be very much having symptoms very much similar to the dry eye, and we have to rule them out and find out if there is any underlying risk factors like contact lens, any systemic medication which the patient is using, any underlying infection, or whether the symptoms and the pattern and the severity of the symptoms do match that of a dry eye. Once you have made a decision that this patient does need a dry eye investigation, you go to the second part, that's the dry eye test, diagnostic test, where you have two things, like one is the screening of the patient as well as the homeostasis markers. And the criteria is that you have to do the test from the least to the most invasive test, as well as what you are trying to find out is whether your tear is stable, and what is the osmolality, and what are the ocular surface changes. And the criteria is like at least along with the screening test, we should have at least one of the homeostasis markers positive. List of questionnaires, there are a lot many, and what we normally use OSDI, as we all know, and it's a 12-point questionnaire which is quite easy, which will give us a higher value, giving a severe indicator of the dry eye. And second one that is recommended by the DUCE-DUE is the DEQ5. With more than 6, it's a positive score. Normally, we don't consider vision testing as a part of the dry eye testing, but doing a functional visual test will be a very good recommendation for investigating in a dry eye, because normally we may see a patient with 6/6, but patient complaining of poor vision or a dull image. And if you try to find out a function, there are some investigative modalities that has been recommended, but I think it is not available in most parts. But you can have a continuous monocular visual acuity measurement with more than 30, during 30 minutes blink-free period will give a fairly good assessment how the patient is feeling about the visual acuity. We know the tear stability we can find out by the TBET, and available if you should start with a non-invasive TBET using any placido-based test that can be projected onto the cornea. And there are softwares available where you can actually map the areas and quantify it as well. If you are using an invasive method, the yellow filter will give you a better, fairly better idea of the and better clear picture of the dry eye spots. It's fairly repeatable, inexpensive, rapid, and recordable. And this is a new trend, like not only the breakup time that we are looking at, it's a breakup pattern as well that we are looking at to find out what type of a pattern it's there, and we'll try to classify the dry eye accordingly. Something interesting that I could find was a flow filter that it's a smartphone application as well as an attachment which can be used for finding out the dry eye or a TBET test. It's quite easy and can be used as a home-based test or for a mass screening or something, and which is quite easy, recordable. You can have the recording which you can show the patient as well and make them convinced like what we are looking at. It's quite easy and very clear image. So coming to the second point is the osmometry, osmolality, that we have the tear lab, which is again we do it without touching the eye. We just look at the inferior fornix and take out a little bit of the tears and try to test the osmolality. It is be temperature stabilized and very calibrated test. If the calibration is not proper, then the result may not be good. A positive test is something about 308 milliosmoles per liter. The inter-eye differences and high variability with a higher value is quite a common error that is possible in osmolality. And third is ocular surface staining, which we all do very regularly. We need to know that we have to stain at least with two stains. One is for the cornea and one is for the conjunctiva. Fluorescent staining, which we normally do, as we already discussed with the yellow filter, it gives a better image, and it won't take 2 or 3 slides more. And conjunctival staining we have to do with the Lissamine green, as well as the lid margin staining we have to look for. So once we have, okay, we can mark it, and as I have told, the ocular staining should be like at least 5 cornea spots or more than 9 conjunctival spots, and at least more than 2 millimeter length of a lid margin. That's the criteria. And ocular surface damage can also be categorized by impression cytology, where you look for the ocular surface damage, as well as an alternate method is for the confocal microscopy.
So last 1 minute for the presentation.
So, and once these two are done, we go for the subclassification for the which type of it is by looking at the tear volume assessment. Of course, Schirmer's and phenol red needs no explanation. And otherwise what you can look for is the tear meniscus height, as well as for the either by the slit lamp or using an OCT, you can look for the tear meniscus height and the volume. And lid margin assessment for looking at the evaporative methods of dry eye, and interferometry will give us the lipid layer thickness, which is also quite easy, but of course it's you have to depend on the machine. If it's not available, it's difficult, but it gives a fairly good idea about the lipid layer thickness also. And biomarkers, we already have a very good session on that, so I'll try to summarize this by saying that the approach to the investigation is more important. That's the key of this topic, and it's the order, repeatability, standardization of the test, and which help us in a targeted therapy. Thank you for this opportunity.
Thank you, Dr. Sujit. Especially the current investigations are very, very important, because with the increasing incidence of dry in our practice, we need to know all the latest modalities of the investigation. So we now invite the next speaker, Dr. Sudesh. Dr. Sudesh, are you around? So I think he's not around. We invite Dr. Bhavna Sharma. She is heading the Department of Ophthalmology in AIIMS Bhopal, and she's doing great work in cornea in AIIMS Bhopal. So over to you, Dr. Bhavna.
Yes. It's a pleasure always to be here at this place, and I thank the chair, Madam Vanati, Madam Manpreet, Dr. Porwal, and all the luminaries present here. And I would be speaking on herpes zoster ophthalmicus today, the evolving trends, and what we could see in last say 4 or 5 years of our study, what has been the pattern of herpes zoster in our center. Thank you very much. And In this presentation, I'll take you through the herpes zoster ophthalmicus, the pathophysiology, clinical manifestations, management, and the prevention. So we all are aware of this entity. It is a viral disease and associated with a painful rash in one or more dermatomal distribution of fifth nerve. The pathophysiology basically involves the reactivation of the dormant viruses in the dorsal root ganglion, and it can affect, in addition to the dermatomal involvement, it can affect the CNS, optical system, auditory system. That is what is concerning us. So about the epidemiology, what we know presently is one major study from US. It tells that there is around 1 million new cases per year in the US. We are in wait for similar such study from India. And the annual incidence as reported is in the 20 to 40 years age group, it is around 1.2 per 1,000 as compared to around 9.4 per 1,000 in adults who's more than 80 years of age. So it is fairly common that 1 in 3 of us will have H0 in our lifetime. It is much more severe in immune compromised, but more than 90% of the patients may not be immune compromised as seen in the recent studies. So a misconception here that healthy individuals are not at the risk of developing or its potential disabling sequelae, whereas in fact we are equally as vulnerable as the immune compromised. The changing epidemiological pattern says that the increasing incidence in the Europe, America and Asia Pacific has been reported. The cause is unknown. They have the implications have been towards the varicella vaccination in the childhood, the environmental factors and dietary factors. The changing epidemiological patterns also tell us that the mean age of onset has now decreased to 52 years, and almost more than 50% of the patients are less than 60 years of age. And this one major study, Merck's, that tells us that though the rate may go up with the age, but maximum number of cases are seen in the 50s. So again, a misconception here that it is only a disease of elderly, whereas it affects, we have seen also that it affects the people in their prime too. The clinical features, that unilateral rash in the dermatomal distribution, it obeys the midline. Now here the pain is important. It can precede the presentation in 71% of the cases, whereas it may coincide or may follow it in 22% of the patients. So we have to keep a watch on these patients who are not presenting with pain, and the pain may make the diagnosis easier, but when it is delayed or when it is absent, it should not miss a diagnosis. We should also be aware of this entity, that is herpes zoster sign pigmentae, where the dermatological, the rash may not be present, or a very minimal rash may be present, but the pain may be there. So we need to identify such patients for a early diagnosis of these cases. And these patients also associated with severe uveitis. There was this study which was done, the Nagel study, which said that only the patients admitted in neurology ICU with stroke said that only 63% of the patients showed a typical history of rash in those patients. So we should be aware of that there is an entity of herpes zoster without rash also present, and it may not always present with a rash. Associations are important. We should be able to keep these patients under follow-up at least for a year, because there have been an incidence of 4.5 times higher risk of stroke in 1 year. The increased risk of cardiac events in these patients have been reported. The event of the giant cell arteritis, where the VZV has been associated, has been labeled as a triggering factor, and the antigen has been isolated from these samples, have been reported from 2 large population-based studies. And also because these patients have responded well to the top systemic steroids. In addition, the lymphoid malignancies have also been associated with them. So clinical manifestations, we are aware about the prodromal phase, the skin lesions, and the disseminated zoster. These are the types of rashes which are of interest. That is the minimal rash and a severe rash, and in between you can see the varying presentation. Now this is the representation of our own cases which we saw, that this is the age group less than 50 years. You can see all varied cases here with minimal rash of present in a lady who just came with us with the history of pain over the dermatomal distribution without any symptom. We followed the patient for another 7 days and she showed the corneal involvement, whereas the rash was minimal or it was not present in that case. So we could identify varied corneal presentation also, from nummular keratitis to keratouveitis to various patterns of keratitis, including pseudodendrite, dendritic, and also anterior uveitis, secondary glaucomas, and other ocular involvement. The chronic eye disease also can be one of the manifestations. Post-herpetic neuralgia may be associated. It is more common in patients more than 70 years of age. We should be able to identify such cases and should be kept in follow-up, and the importance is that we should be starting them with adequate antiviral measures at the earliest point of diagnosis. The recommendations is for the oral antivirals to be started to all patients within 72 hours. It can be acyclovir, famciclovir or valciclovir. It reduces the incidence of chronic eye disease, and intravenous acyclovir, systemic steroids as required in encephalitis. The dose for immune-compromised patients varies. It is higher as compared to immune-competent patients, and foscarnet is generally reserved for patients who are typically, acyclovir resistant. Management of ocular involvement is as per any standard protocol. It includes the antiviral ointments, lubrication, control of anti-glaucoma medications, and as and when required, if there is an epithelial defect with the BCL, tarsorrhaphy, AMT or conjunctival flap can be given to the patient. The posterior segment involvement also, the treatment depends on the presentation. So also the dendritic keratitis, a word here that it is proven that the dendrites have shown the presence of the VZV have been isolated from them, so we must always endeavor to give them antiviral. Prevention is important, that there is recommendation of vaccinating individuals who are more than 60 years of age to prevent the incidence of herpes zoster ophthalmicus, which is increasing, and the overall vaccine efficacy is around more than 97% in such cases. One point which should be noted is that it should not be given when the patient is on antiviral treatment. So the carry home message I would like to give here is we must always look for very mild rashes also in such patients, because the disease is increasing in the younger age group as well. We must also be aware of the herpes, this entity of herpes zoster sign pigmenti, because we would not know that which patient will go on to the serious complications, and begin treatment as soon as possible. Of course, there's a recommendation for starting HZO vaccination for people more than 60 years of age, and we have started at our center as well. Thank you very much, and this is my team at AIIMS Bhopal. Thank you.
Thank you. Dr. Rupal, would like to invite the next speaker, Uma Sri. Very nice elucidation by Dr. Bhavna. Dr. Rupal.
I would like to now invite Dr. Uma Sridhar to talk on collagen cross-linking. It was really a very extensive and nice presentation.
Thank you to the chair, and thank you to RPC for inviting me. This is a very vast topic, and I hope I am able to do some justice to it.
Next.
Yes. Next. So I have tried to divide my topic into past, present, and future. Earlier it was thought that Professor Seiler, on going to his dentist, he found that cross-linking could be done, but actually early American papers have shown a relationship between age and collagen oxidation that finally reduced his turnover. And it was found that higher protein glycation, that was the Maillard reaction of corneal collagen in diabetic patients, there was an increase in biomechanical resistance. So this and other aging studies were the basis of actual cross-linking therapy that we use. And it is a chemical physical process, natural or induced, that produces covalent interfibrillar links modifying collagen structure. And the first studies, as we know, were by Spohr and Seiler in the Dresden University. And we find that more linkages happen. And the photosensitizer riboflavin administered with UVA applied, and it has an oxidative pathway and a glycosylation pathway. And so we find that when you remove the epithelium, that is the greater drug penetration, and with the epithelium on, there is little less penetration. The indications, as we all know, are mostly for the ectasias, where the keratoconus is the most common, pellucid, post-LASIK, post-RK ectasias. The first protocol was the Dresden protocol with 30-minute pre-soak with riboflavin 0.1% and 20% dextran, and with 3 milliwatts for 30 minutes. And then we found that the patients were very uncomfortable, so there was a debate on the epi-on versus epi-off. As you can see in the OCT picture, that epi-on seems to be more effective with a deeper demarcation line as compared to the epi-off. And the epi-off was more effective. Many studies are there on that. The epi-on, of course, reduced the risk of infection, caused lesser haze, fewer delays in healing. And there were supplementary topical medications like tetracaine, benzalkonium chloride, EDTA, trometamol to disrupt the epithelium, improve penetration of riboflavin. We have also tried using the Sinskey a dialer to make crisscross patterns, break up the desmosomal attachments and allow for better penetration. So the various studies showed between the results of benzalkonium associated transepithelial cross-linking, you could see that they were less effective than standard CXL in progressive keratoconus. So there were many studies based on that. So how could you actually increase the efficacy of riboflavin? So they added vitamin E enhanced riboflavin solutions and low dose UVA, and there were clinical outcomes on that. The increased efficacy of riboflavin penetration was also tried with iontophoresis, which consists of transfer of molecules with an ionic charge inside the tissues to treat thanks to a low intensity electricity field, and it helped the penetration of riboflavin in epi-on cases. There is also something called phonophoresis, which is postulated that the phonophoresis enhances pharmacological delivery via radiation forces, acoustic streaming and acoustic cavitation, and there's an ultrasound device. There have been 1 or 2 studies on this, but basically they are animal studies. Here you found that actually the thermal levels are higher, so it may actually damage the endothelium. Oral riboflavin is a new approach without the need for epithelial debridement and involves administration of oral riboflavin and natural sunlight exposure. So the patients ingest high doses of riboflavin and are exposed to 15 minutes of direct sunlight while engaging in desi exercises. Very few studies are there on that, but here the disadvantage would be that they could have sun exposure and quicker aging process. The enhanced solution, you can increase riboflavin concentration from 0.1 to 0.35% or use substances like we said vitamin E to increase epithelial disintegration. Accelerated cross-linking, you are tired of the patient lying 1 hour on your surgical suit, so actually you use 9 milliwatts for 10 minutes. We have done several studies on this. There were also some colleagues who said that they debrided the epithelium on the slit lamp and told the patient to keep putting the riboflavin drops in their OPD and then took the patient to the OT for just 5 minutes. Now this is based on Bunsen-Roscoe's law of photochemical reciprocity, which describes a linearly proportional photochemical effect to the total UV energy delivered regardless of the duration of administration. So there is but significant reduction in oxygen availability during CXL at higher UVA irradiances. It reduces strengthening effect of the accelerated protocols. The short illumination duration with high UVA intensity provides decreased time for oxygen rediffusion to occur to produce oxygen-mediated crosslinks. Now, how do you improve the oxygen diffusion? Oxygen is a key component of the type 2 oxidative pathway in the reaction between riboflavin and UVA. So I think in the earlier session it was said, pulse fractionation of UVA radiation may improve cross-linking efficacy by allowing rediffusion of oxygen during the pauses between the UVA pulses. The supplementation of oxygen has also been shown to increase the strength and depth of CXL. So a wearable oxygen delivery device known as BOOST is a recent approach to epithelium-on cross-linking. It creates a hyperoxic periocular environment, and there were ex vivo studies showing that periocular oxygen supplementation provides more corneal stiffening. In thinner corneas, again there have been lots of papers published on this. You could use hypoosmolar riboflavin. The de-epithelialized cornea can swell to double its normal thickness when irrigated with a hypoosmolar solution. So dextran-free solution was then administered until the corneal thickness of the thinnest point reached 400 microns before initiation of UV radiation. We have also used distilled water in our own studies, and we have also used intraoperative pachymetry to check the thickness. Nowadays we are using non-dextran with HPMC, and we actually find that pre-op it is 400, it actually becomes even 500 after that. So transepithelial cross-linking by adding enhancers to help riboflavin to penetrate, it can be performed without epithelial debridement. Contact lens associated cross-linking is another method. So also smile lenticules, but nowadays Hafezi et al. Have made nomograms. So instead of modifying corneal thickness, sub 400 protocol adjusts the UV illumination time and irradiance. There is also in the future ultraviolet A emitting device called Kera Bio, which utilizes UVA emitting glasses and topical epithelium on riboflavin for 3 hours daily across 6 months. And it allows patients to be ambulatory. The future is also the CI device, which allows the treatment in the slit lamp. And here you can use with a optimized irradiation profile. So PAC CXL we have also tried, but not to too much efficacy because most of our ulcers were fungal. We also had 2 perforations in that. Photorefractive intrastromal cross-linking device allows specific patterns to the cornea based on the patient's topographic data. There is also customized cross-linking to reshape the cornea. The conventional cross-linking achieves by stiffening 9 mm and the customized gives specific patterns. Photorefractive keratectomy has also been done, the Athens and the Cretan protocol, which involves performing through transepithelial
Ma'am,
photorefractive
last 1 minute to
keratectomy.
conclude.
Thank you. Yeah, just so correction of low myopia is another which is being used nowadays. So the contraindication would be pregnant patients, herpes simplex reactivation, ocular inflammation, and poor epithelial wound healing. There are complications which we have also faced with cross-linking, so it should not be taken very lightly. Thank you.
Thank you, Dr. Uma. I think that's a very extensive topic to cover in just about 6 minutes here. If there are any questions for Dr. Uma and for Dr. Bhavna, we'll take it in the meantime when Dr. Ashok is setting up for his talk on endosaver assisted ultra-thin DSEK. Oh, a question for Dr. Bhavna here. Yes. What is the efficacy of herpes zoster vaccine? And I know you recommended it on all the elderly patients, but I think there are reports which do say, of course, it's not 100% efficacy, and it's about 97%. And I think there are articles which do talk about those who do get herpes zoster, the morbidity tends to be more in those who have been vaccinated. So that's one thing we need to be aware of when you are advising, and this is a point to be discussed, especially I think we would advise more in the immunocompromised patients as a prophylactic scenario here. That is my current understanding. Anything you would like to add on that? Mike.
Increasing incidence of herpes zoster in young patients, and these are the breakthrough infections mostly because of the wild vaccines, wild viruses they say, and also the nutritional imbalance. So our dermat department and we had a common proposal also. So they were also in the view that maybe we can start giving this vaccination for the elderly patients. Of course, in all patients who are more than 60 years of age, that also for this reason that in these patients they have said that it is the post-herpetic neuralgia would be less and the complications would be less if at all they tend to have that, even if the efficacy is 97%. The rest of so the severity would be less and the incidence of post-herpetic neuralgia. So it is a joint this thing of Dermat and our department that we are now come up with a proposal of increasing of VZV vaccination in these patients of more than 60 years. The studies, of course, as I said, have said that the recommendation is for the patients only because there's an increasing incidence and they are the wild, breakthrough infections of the wild VZV virus.
At the outset, I would like to thank RPC team. Professor Vanathy is here to give me opportunity to share my experience of using endosaver in ultra-thin DSEK. Endothelial keratoplasty has undergo great evolution, and these stalwarts have contributed a great. Of various indications for endothelial keratoplasty, Fuchs endothelial dystrophy and pseudophakic corneal edema remains the most common. We know that the thinner the tissue, the better the visual outcome, and therefore there has been always an effort to decrease the thickness of the donor tissue, and the terms like ultra-thin DSEK and now nano-thin DSEK have been introduced. The two major challenges in ultra-thin DSEK are, one is to have the donor tissue preparation and the second one is insertion. Donor tissue preparation, we have two techniques. One is double pass technique. The first step is the debulking step, and the second step is a refining step, which is based on the residual stromal thickness, and then we select the head. But more common is the single pass technique, and most of the eye banks use these techniques, and we can achieve thin tissue, obtain thin tissue using this technique. And there are several studies which confirms that this single pass technique gives predictable results. Coming to insertion, in my experience, forceps
sheet glide or suture pull through are not ideal for using very thin tissue. You always need inserter to handle these tissues. Fusion glide, we have great experience and we are comfortable. But for very thin tissue, my choice is this instrument. This is just like IOL injector. It has a plate on which we place the tissue with endothelial side up, and we connect to the IA and we keep it very minimum. Then we have thumb screw. We rotate it. This plate becomes a tube and enter into the AC. Then we rotate the deployment wheels and the tissue is automatically inserted into the anterior chamber. Now, this is a small video to show this technique. In this case, we, as usual in other cases, we always mark the center and then we have a guide to place for the placement of the tissue, and after removing the epithelium and then making the entry point, we remove the Descemet's membrane. And for using endosuture, we need 4.5 millimeter entry. And once you have made that entry, this is the instrument. You have a plate, and then you place the donor lenticule, which is very thin, on this, and then after making it orientation proper, and then we rotate the proximal button, and this is getting converted into a tube with endothelium inside and well protected by this tube. And after that we insert, we keep very low irrigation and insert this tissue into the anterior chamber. Now you can see that because of very thin tissue, the recoil capacity of the tissue is less. So we have to make the AC and then air injection is done, and finally the procedure is completed. There are several studies which have shown that the endosaver gives better endothelial cell count and has ease of use. I started with the manual DSEC, getting good results, but there were several surprises in terms of vision. Shifted to automated and then ultra-thin DSEC. This is one patient where we have done DSEC, ultra-thin DSEC with phaco. On first post-op day, had some edema. At that time, we didn't have anti-segmentosity. So I would like to emphasize that even the Pentacam can give you an idea that the lenticule is separated. So we gave the air injection and it improved significantly. This is the second case where we have done ultra-thin DSEC with endosaver and with good result. These are the parameters which we have, donor parameters which we have used. Most of the times the thickness is less than 100 micron, and I have used thickness up to 77. And endothelial cell count, I always try to choose higher endothelial cell count for my patients. The beauty of ultra-thin DSEC is that further with the follow-up, the tissue further thins down, and this is one case where it has thinned down to 65 micron. This is one patient who is deaf, who is dumb and blind, and she has severe dry eye because of rheumatoid arthritis. There was no other way to rehabilitate her, but ultra-thin DSEC rehabilitated her. She is enjoying good vision. Now, comparing to DMEC, definitely DMEC has faster visual outcome, and it has also advantage of giving better sensitivity and less posterior corneal aberrations and more patient satisfaction. But ultra-thin DSEC can give you almost equal visual results and has several other advantages, like it doesn't require the long learning curve as DMEC. Thank you, and I would like to conclude by saying that endosaver assisted DSEC is safer, predictable, and causes less endothelial loss and can give better visual results. Thank you so much for patient hearing.
Thank you, Dr. Ashok. And do we have Dr. Sonu Goyal here? Not here. So I'll invite the next speaker, Dr. Rupal Shah, to talk to us on the novel use of smile lenticule. I think we are putting the smile lenticule to multiple uses right now. And as she is setting up any questions for the earlier speakers, I have one for Dr. Sujit. I think he did speak about functional visual acuity. So would you like to elaborate on that and how we can probably use that in dry eye patients?
Yeah, ma'am. The functional visual acuity actually it is not recommended in the adults classification, but what we see is often we see patients complaining about poor vision, and when we check in the Snellen acuity, we'll find them as having 6/6 vision. But that's in the practical life. They may be, when you are staring at something, you are reading something for some time, at least 30 seconds. without blink, your tear film is getting unstable. So even a Snellen acuity reading, you can do with the patient keeping the eyes without blinking. Probably you'll have an assessment of like what patient is having, so that you can make it as a part of your routine dry eye examination. So that's what. And there are some Japanese machines have been. I could find it in the websites and all that, which can actually quantify this functional vision also.
Yes,
but I'm sure it's not available
I
now.
think I completely agree that patients, when we do check their visual acuity, they are 6/6, but then they are very, very uncomfortable because of the poor tear resurfacing, and the functional visual acuity, or for the acuity which they have when they are performing their day-to-day activities is much lesser, especially as they are, most of the time all with blepharospasm and closed eyes here. So I think once we have a commercial device on that which is freely available, that would be another addition to our all that we do have on the anvil for dry eye assessments. Thank you, Sujit.
Good morning. And at the onset, I would like to thank RPC for the opportunity here, and also like to congratulate for more than 50 years of great work. So it's really been a boon for Indian patients. Today, I would like to talk about novel applications of SMILE lenticule. SMILE, for the uninitiated, is becoming increasingly a very popular form of refractive surgery, where we extract out a lenticule from the corneal stroma, and the shape and thickness of the lenticule that we create defines the correction of refractive error. So normally it is discarded immediately after the procedure, but it is an avascular natural tissue, and if stored easily in a corneal preservation medium, why not try to use it? So every time I would throw away that lenticule, it would hurt me, and therefore we thought of some novel uses of these lenticule, which were natural normal tissue. So some applications that we could think about was using the lenticule to treat hyperopia, using it to stabilize the cornea in keratoconus, using it to increase corneal thickness, to increase the safety in corneal cross-linking for the treatment of keratoconus, as was pointed out before, using it as a patch graft to cover thinned out areas near the limbus, and using it to prevent tube exposure in glaucoma drainage devices. For hyperopic treatment, it was tried long time back by Professor Osama Ibrahim to treat hyperopia by inserting a lenticule which was formed from a myopic patient into a hyperopic patient by creating just a lamellar dissection. So a donor small incision lenticule extraction match for a refractive error is implanted into the recipient's corneal pocket. This pocket is created at a greater depth, about 160 microns, and this can be combined with Bowman's membrane relaxation to treat any residual refractive error. Another possibility is also to create a flap and put the lenticule, but the one which is put in a pocket seems to be working the best. There was also a presentation by Dr. Sri Ganesh and group, which they've named as FILI for hyperopia. This hyperopic treatment is not taking much traction because hyperopic treatment on the cornea has limitations to be treated only till 3 to 4 diopters. LASIK is also working good for that. Beyond that, if you modify the corneal curvature too much, it's causing a lot of aberrations and not really stable results. And therefore, anything to do with the corneal hyperopic treatment doesn't really work as well for very high hyperopic corrections. To treat keratoconus, we usually take a lenticule and punch out the center so that you have only the peripheral ring, and then put it in the keratoconic patient, and this would act like an intact for keratoconus. And this also has been worked upon by several centers, and it seems to be working well in some hands, and there have been also presentations. In ultra-thin corneas, as was pointed out, it's a challenge to do corneal cross-linking, and so we also tried putting the SMILE lenticule. This is the way we were putting it on the eye. You can actually remove it. This is how we would remove the lenticule. So the lenticule was put on the patient's eye, and this is how it looked. And this is how it was cross-linked. As a patch graph over glaucoma drainage device, our Center for Sight Center at Surat, Dr. Amit, tried this. Glaucoma drainage devices are the treatment for choice for refractory glaucoma. But the tube exposure is a major complication which can be a devastating consequence like endophthalmitis. To prevent this, a layer of patch graft is usually used to cover the tube. Many different graft materials have been used in the past, but corneal tissue seems to be the best due to its tight structure and good aesthetics. However, lack of corneal sources, especially in developing nations, is a major disadvantage. So what we did was the tube was inserted into the anterior chamber and sutured to the sclera. Then a folded lenticule was placed over the long axis of the tube, making sure to cover the point of insertion of the tube into the sclera. And the scleral bed was then dried and fibrin glue was applied. And we put a second corneal lenticule on top of that. So it was 3 layers which was covering that particular tube. And then conjunctiva was closed with over a triple layered, and this is what it looked like finally. So it was really a very gratifying experience. You can see at the extreme left that is what the tube looked like. It was very cost effective. Cosmetic appearance was ideal. Tube was partially visible through the transparent graft, so blockage or ligature could be observed. There was no preparation required in the eye bank. It was very easy to manipulate. Laser cut, so there was no irregularity, no sharp or ragged edges. There were lesser chances of conjunctival retraction or Dellin formation. Devoid of epithelium and uveal tissue remnants, so the tissue reaction was much less. And it was acquired in a sterile OT environment, so lesser chance of contamination than traditionally acquired donor tissue. So it really worked well. So we even applied it for severe corneal thinning procedures like this, where we just put it, sutured it, and the conjunctiva was laid over it. The challenges were laws around organ donation. Infection and rejection were the 2 potential risks in the reuse of lenticules, but no consensus has yet been reached on the best method to provide safe lenticules that maintain integrity and clarity and do not trigger tissue reactions, and various options are still under investigation. Right now what we did was we just removed from one patient and put it immediately in the other one. So we had both the patients ready. Decellularization, in which cells can be removed so that only the collagen fibrils architecture of the lenticule remains with no trace of donor's DNA, could potentially increase the safety of lenticule transplantation without compromising the efficacy. And I think efforts should be made towards that end. Thank you very much.
Thank you, Dr. Rupal. I think there's a lot of work on using SMILE lenticules in research modules as well, where they are using it for several of these acellularized stromal implants as well.
Yeah, this was just to throw the idea so that people can apply it more.
I think there is also a lot of work on using the SMILE lenticule as a tissue addition procedure in keratoconus of late. I think there are a lot of confounding factors on that. So we are still working out on what works best for our patients to, as an interim measure where we combine it with cross-linking when we are doing for some of the keratoconus patients here. Yes. I'll just invite the next speaker, Dr. Tushar, for his talk on post-RK and post-LASIK cataract surgery challenges and solutions. And as he's setting up, yes, Dr. Bapna.
No, so we de-epithelize and then put the stromal lenticule. So So we found the efficacy to be the same as normal dressing.
kind of expansion of that. I'm curious because the lenticule is smaller in size, right? So you will have a peripheral effect when the demarcation line goes too deep. What device are you using? Is it
No, so what we do is we put it on the cone. So we decentralize that stromal tissue. So it's like more like a customized
what happens to your peripheral depth? Because the overall thickness of the cornea, this is a thinner cornea, right?
Yes.
So you are doing this when you are not able to pull up the cornea to save for endothelial.
Yeah, so we are protecting the thinnest point.
Yeah, but your peripheral rim.
Yes, it's still getting exposed.
Will still have the same
Yes,
treatment, right?
it would.
So do you have a step demarcation line happening over there? Like you have a demarcation which is deeper in the periphery and then goes up shallower? Have you seen that happening?
No, not really. Not really very significant change in that pattern of demarcation line.
That has not been published in the Sachdeva group study
Yes.
also, and I was kind of curious to look at that. Because that is a potential risk for two things: peripheral decompensation, because you're going full blast, you're using the same power, and this is before the Havezzi protocol came up. So we kind of thought of this idea backwards in because we didn't go about because it was not in state.
Ma'am,
Second thought
can we
I
move
had
to
was
the
that
next
this
speaker?
will also lead to something called as a peripheral hyperopic flattening, because you're going deeper and you can have a more pseudomyopic shift in these patients. This is a very curious thing to see what happens with this thing.
Yeah, we've really not found it so much of a difference between the two areas.
I think very valid points and very valid thoughts, which we probably would need to look into the step demarcation lines, the peripheral endothelial decompensations, and when the corneas are too thin, where does the demarcation line really remain? Is it deep enough or it's still shallow? Is something which I think we need to take on further studies. And good points raised there, Gaurav, as well. Yeah, over to you, Tushar.
Thank you, ma'am. It's an absolute honor to be here at the RP Center for the Foundation Day celebrations. So I'll be talking about post-RK and post-LASIK cataracts, the challenges that we face and the solutions that we currently have. So, of course, the challenges include pre-op, intra-op, and post-op challenges. I'll be starting with the pre-operative challenges. So probably the biggest challenge that we encounter in these cases is the keratometry and consequently the IOL power calculation in these cases. It's also a challenge on deciding which lens to place. Should you go for a monofocal or a multifocal? What should be your target refractive error as well is a challenge. Now, the limitations that our optical biometers, keratometers, and the Placido topographers have is that they are basically measuring only the anterior corneal curvature. They are not able to measure the posterior corneal radius, and they assume that ratio between the posterior and anterior corneal radius. Also, they are blind to the actual corneal center, and this is information that needs to be extrapolated in them. So this is where Scheimpflug tomography helps us, because it is able to take into account the refractive effect of the anterior as well as the posterior surface. So the preferred map for me is the Pentacam equivalent K reading map, which I use for calculations. The reason why this is helpful is, to begin with, it calculates the equivalent K readings using Snell's law and converts them finally in a two-step process into values which can be directly used into your IOL formulas. Now, this is what the Holiday EKR report looks like. You have the EKR readings which are in different zones, which are centered at the pupil that is there in front of you. You also see a histogram showing the relative frequency of EKR. So when you have a histogram like this, you can see it's a very uniform EKR having one large single peak. So that indicates that this is an extremely regular cornea, and in somebody like this, I would be okay with placing a multifocal lens. Whereas when you see somebody like this, a widely spread histogram, the standard deviation is also quite high, I would be very, very hesitant to place a multifocal lens. I would not go for a multifocal lens. But if you can see, the keratometry values are reasonably constant across different zones. So I would go ahead with a toric IOL in this particular case. There is some guarded, this thing, you're not going to get absolutely perfect outcomes, but the patient would be better off with a toric IOL than with a conventional monofocal IOL. And what is important is that you can feed these values directly into the ASCRS online calculator, which gives you an average from different formulae, and you can use the average of these values and get the most accurate IOL power calculation. Now, as far as the target refractive error is concerned, for LASIK, I go for a plano target because you don't expect too much refractive shift to happen post-operatively. Whereas when it comes to RK, you should be targeting myopia. The more the number of cuts, the more myopia you should be targeting because of the hyperopic shift that happens subsequently. In spite of all of this, there are rarely cases where you don't have definitive answers, such as this case, which was a patient who had undergone LASIK in 2008. We're planning a cataract surgery now. It's a high myope, as you can see from the axial length. What is interesting to see here is how flat the cornea is. You can see the K mean value of 25. When you look at the EKR map, values as low as 21, 22 diopters in some zones. So when I try to calculate, the calculator just refuses to accept these values and tells you to go and check your values instead. So that's when I realized that the lowest value that the ACRS calculator actually accepts is 31. So there is absolutely no definitive way for us to calculate the IOL power in this case. So what we had to do was to extrapolate the information, see how the IOL power was changing as we moved up from 31 to 32 to 33, and try to extrapolate how the IOL power would be at about 25 diopters. This was the only option. The other option would be, of course, to leave the patient aphakic and do a subsequent IOL power calculation. So we were fortunate, to a certain extent also lucky, that we were close to the refractive target. We did have some residual hyperopia, but it was not extremely high. So this is a case which you really don't have an answer to. Now, coming on to the intraoperative challenges, the biggest considerations in post-RKIs is where to place the incisions. So if you have 8 incisions or sometimes even 12, you can place the incision clear corneal between the RK incisions. But if you have more number of incisions, you have to go for a scleral tunnel. It's also important to keep the parameters reasonably low, fill the chamber with viscoelastic when you're withdrawing your phacoprobe, etc., because those RK incisions can open up, so you don't want too many chamber fluctuations to be happening. In post-LASIK eyes, one of the most important considerations is the position of the flap. You should not be disturbing the flap, because if you do that, you can have epithelial ingrowth, etc., happening in that area later on. So this is a case which had a leaky incision post-cataract surgery. So these cases, you just have to suture that RK incision. Otherwise, these patients do fine. This is a patient undergoing flax post-RK. You can see how flat the cornea is. Another consideration when you're doing flax in these cases is that you might have uncut capsule tags in the area of the RK incision. So you have to be a lot more gentle with removing the anterior capsule, remove it like you're doing a manual capsulorhexis. Here again, this is a flax, but we are placing the incisions manually and placing the incisions in the area between 2 RK incisions. So moving on to the post-operative challenges that you have with these cases. Like I said, hyperopic shift is a common issue with eyes that have undergone RK, which is why you should be targeting myopia in these cases. Additionally, what happens is that the RK incisions often swell up post-operatively, immediate post-operatively. So you can have a hyperopic refractive surprise to begin with. So in these cases, you just have to wait and observe and not be in a rush to do any form of recorrection or any form of additional refractive correction, and let that hyperopic shift settle down. Once the cornea, the edema goes away, the refractant does come back closer to your target. And finally, no matter what you do, there is always that possibility of refractive surprise, particularly in patients who've undergone an RK or in patients who've undergone a LASIK with extremely flat corneas like the one that I showed you. So that's something you should be aware of. So to summarize, IOL power calculation is probably the biggest challenge. Corneal tomography and ASCRS online calculator do help significantly to improve outcomes in these cases. Post-RKIs do have that challenge of where to place the incision, and you can have leaky RK incisions during or towards the end of cataract surgery. Refractive surprises, like I said, are possible, so extremely thorough counseling and possibly a special consent if you can is important, especially in those extremely challenging, extremely flat corneas or extremely irregular corneas. Thank you. Thank you so much.
Thank you, Tushar. I think to add on to that is, this is one scenario where an intraoperative aberrometry perhaps is going to be of particular use to decide, especially your spherical and your toric components can be refined. But a word of caution is that the imaging can be variable, and it is more dependable only when you have 8 RK incisions on the cornea. So that's an add-on point to you. And I think the most favorite question which everybody asks when you're presenting a talk on post-refractive surgery, IOL power calculation, which formula works best in your hands?
Ma'am, to me, honestly, I like to take the average from different formulas in the SCRS online calculators. You do usually get good outcomes with the Barrett 2K, but getting an average, even if you don't have the pentacam values, even if you just have the optical biometry values, you feed that onto the SCRS calculator, it will give you 3 formulae, and taking the average of that is what works best, in my opinion.
So I think the take-home point is that multiple imaging modalities, you look at whatever IOL power calculation, irrespective of the formulas is used, and still the Barrett's is perhaps the most dependable. Some of us post-LASIK, we do like you to use the Haigis as well. Then we do use it over a variety of devices to look at your biometry recommendations, and would probably err on the side of choosing the one which has the most common, which is most common, and also the one which has the slightly higher values as well. Anything else which the panel would do? Dr. Rupal, Dr. Ashok, your thoughts on these?
If the person is just too keen on not wearing glasses, which that to begin with, because that's why they got the LASIK done, would you recommend a EDOF lens or a multifocal lens, and would you do it as a 2-step procedure, or would you do it in the same
Yes, ma'am.
setting?
So that's where the holiday EKR map helps you, because if you have a single peak and extremely uniform cornea, those patients you can consider an EDOF and even a diffractive multifocal if it's an extremely regular cornea. Whereas if you see a spread out histogram map on the EKR map, it indicates clearly that it's an unhealthy, it's an irregular cornea. In those cases, definitely no. Something like a Vivity can be considered, but I would still choose a monofocal in those cases.
In these patients, one of the problem is of like glare because of the irregular cornea, especially if you have multiple incisions. So I saw one patient who came from outside. He has been operated and the lens has been implanted, which has a sort of a pinhole effect. It has a dark circle and then sends to decrease this glare. So I don't know which company, but this kind of lens can also help you.
Yes, I have seen that, but I don't have any experience with that. Some patients with extremely irregular corneas post-RK also monofocal lens, and you can consider a scleral lens in those cases for patients to have good vision. That's also
another take-home message is that most of these patients, those who have highly irregular cornea, we should make an effort to see whether this patient will be benefited by cataract surgery or IOL implantation or not, because sometimes the cornea is too irregular and they may require scleral contact lens to improve the vision.
So when it comes to RK, I mean in Indore we see a lot of RK patients. So even after RK, they underwent RK to be spectacle free, but they do have residual refractive error, and now they don't want to wear the glass and they are ready to accept the compromised vision. So I would go for a Barrett calculator and for a monofocal lens, explaining him that you still have a residual refractive error and your refraction will be variable. So I always would prefer a monofocal lens, and a small aperture, that is a small aperture lens. I don't think it's available in India yet, but it is available abroad, and it's basically a pinhole lens. So all the aberrations are taken care of. It's a pinhole vision what you get.
Okay, I think several patients, near vision assessment is something perhaps a key, and when their near vision is still good enough, as Dr. Ashok rightly pointed out, a scleral contact lenses will perhaps be a better option and delay their cataract surgery till you really need to interfere with these patients. Yeah, so I think that's particularly a very difficult
delaying
scenario.
the cataract surgery, these patients present to us with a brown cataract only.
Because it's already
myope,
I agree.
RKs,
I agree.
they present to us with
Talking
brown
about
cataract.
those where they do come on early to us when you're about say 45 or so, and that is when the presbyopia sets in. They are really unhappy with their visions, and I do see a lot of surgeons jumping in for cataract surgery at that point of time. So that's when a very thorough workup and evaluation is perhaps the best before you decide what is going to be the best modality which will work for that particular patient.
We have few patients where they had like wide dense cataract and they have been operated for that, but vision didn't improve, and the cornea was too steep to even fit the scleral contact lens. You had to go for corneal transplant surgery.
I have a question for you. Thank you, Tushar. What is your idea about topolinking along with topolinked surface ablation along with C3R?
It's a very controversial topic. We can talk all day on that.
Yeah, but what do you do? Do you ever do that?
Use the TopoLink proprietary software yet to be clear on that. But topography guided treatment as such, I'm not a great fan because it does not look at the visual line of sight. We don't see because the cornea, we see because the line of sight. As long as you can fixate the line of sight and get a wavefront guide treatment through the cornea, the purpose of see from a user perspective and say the outcomes. The outcomes have been good, at least what I've heard about people saying. But it is probably as good as using a good wavefront guided software.
Then your patient selection is perhaps one of the most key
in
factors.
corneal cross-linking.
Cross-linking, so as they were using
No, not in regular ones.
topo guided cross-linking. I think we're still way far away from reaching that point right now. Pixel is the next step right now. I don't know where they are in terms of their commercialization.
Yeah.
At least in
Before we close, I thank all the speakers and the panelists and my co-chairs for this wonderful session. I think we really enjoyed the discussions. And may I call you on in the front for a quick photograph, please. And many
thank you
thanks
all
to the
chair-
audience as well for being with us here. Thank you so much.
And thank you for all the chairpersons for wonderfully chairing this session, and all the speakers for keeping it in time, most importantly. So thank you everyone for these wonderful presentations. We shall now move to the main hall for the oration sessions. Check. So welcome back, everyone. This is our last session for RPC Ophthalmic Carnival 2023. For this, from basics to advance, may I welcome our chairpersons, Dr. Madhu Bhaduria, Dr. Naiviti Lumi. We are going to be joined by Dr. Nupur Gupta, Dr. Saurabh Verma, Dr. Devesh Kumawat, along with our moderator, Dr. Devang Angmo. May I request the moderator to please take it forward. But before that, let me just remind all the speakers that the time limit is 7 minutes for the presentation, so please keep it in time. Thank you.
Okay, so you have put a timer for 6 minutes?
And after that, I'll just say it.
Okay, fine. Thank you so much. To kickstart the session, I think I'll call upon Dr. Ikeda Lal, who would be presenting on pterygium excision with conjunctival autograft surgical tips.
A very good afternoon to all of you. And today I'll be talking and sharing a few surgical tips when it comes to pterygium surgery. So let's understand the goal of the surgery. There are two main goals of surgery when it comes to pterygium. One is to achieve a good cosmetic outcome, and second is to minimize the chances of recurrence, as we know that is the major complication. And both these goals are fulfilled by the conjunctival autograft technique, which was described by Kenyon et al. In 1985. Now, before we talk about the surgery, let's look at a few preoperative concerns. The anesthesia used could either be peribulbar or subtenance, and the position of the surgeon could be superior or temporal depending on the comfort. Sitting superiorly helps in harvesting the graft with a little bit more ease. Using topical brimonidine 10 minutes before the surgery actually helps in decreasing the intraoperative bleeding. Now, let's understand the parts of the pterygium, and that will help break down the surgery for us. So, head of the pterygium is the part which overlies the cornea, and then we have the body of the pterygium, which is the part which overlies the conjunctiva, and the junction of these two is called as the neck of the pterygium. Now, this whitish degeneration, whitish tissue that we see here is actually the elastotic degeneration, and when we are excising the subconjunctival tissue and the conjunctiva, we need to make sure that we remove all of this degenerated tissue. So whenever we need to perfect a surgery, we can break it down into steps and then understand in detail each of these steps. So if we have to break down the pterygium surgery into different steps, it would be excision of the head of the pterygium, followed by dissection of the conjunctival tissue, and then harvesting the autograft, and finally securing the graft in place. And there can be different techniques of securing the graft in place, and I'll be sharing these towards the end of my presentation. So let's first understand how to excise the head of the pterygium. So here are two different videos and two different ways that I am doing this. The first video here, we are just stripping the head of the pterygium from the corneal surface using two sharp forceps. And then in the first video here, we have excised the head of the pterygium and then clearing off the remnant tissue with the help of a number 15 blade. And in the second video here, first we have gone ahead and undermined the neck of the pterygium and subsequently freed the head of the pterygium so that we have free tissue here, and then stripped it again using two sharp forceps, tooth forceps, which helps in giving some traction. And then we again subsequently clear off any remnant pterygium tissue. Now, very rarely we might come across these large adherent pterygia which have a significant amount of underlying scarring, and this technique might not be very helpful for cases like these. So here a crescent knife is what comes in handy. So once we have dissected this tissue off, we need to go in and remove all of this remnant tissue again. So this video has been shared by Dr. Namrata Sharma, and we can see here how beautifully she's using a crescent knife. We have to be a little careful with crescent as it is very sharp, so we have to avoid doing a multiplanar dissection or going too deep. And then this has the tissue has been excised, and then we can proceed with the rest of the steps. So now, before we talk about the surgery, we'll talk a little bit about the harvesting the conjunctival autograft. Can we play this video, please, from there? Okay, yeah. Right. So once we have dissected the subconjunctival tissue, we measure the defect that we have created, and then accordingly we can harvest an autograft. It should ideally be a little larger than the defect because it can always be trimmed to size. And here the aim is to try and get a thin autograft with minimal amount of subconjunctival tissue or the tendons. And the thinner it is, it sits in very beautifully and doesn't tend to balloon up. So here we are going ahead with the Vanna scissors to carry out a little bit of fine dissection, and we can see even after making the graft and flipping it over, we can excise some of the subconjunctival tissue and then flip it in position and put it in place. So now let's look at the entire surgery. So I'll skip this step because we have already showed this video about how to excise the head of the pterygium. And once we have cleared off the tissue from the cornea, we have to excise all the subconjunctival tissue as well. So here we are using a combination of blunt and sharp dissection techniques. So either your assistant can hold the conjunctiva or the tendons, and the other can be held by you. And then here we are going in with our scissors closed and opening them up as we go in. This helps in avoiding buttonholing and as well as effectively dissects off all the degenerated tissue. So we excise the tissue. And then after this, measure the defect and then create the graft. So one tip here is when we are harvesting the graft, you can ask your assistant to just use a bud or a Merisel sponge and rotate the eye down towards downwards inferiorly and to the nasal side. This beautifully exposes the superotemporal quadrant and makes it easier for us to harvest the graft. So we can use subconjunctival lignocaine or BSS, and we can even mark the graft if that helps the surgeon. Now, important tip here is when we are using fibrin glue is to use both the fibrinogen and thrombin components separately. This helps in preventing the clumping of the glue and gives us a nice thin layer of the glue. Then we secure the graft in position and iron it out using a McPherson's forceps. A very important step to improve the cosmesis is to trim the overhanging tissue which is over the limbus. This greatly improves the cosmetic outcome. Now let's talk about anchoring the graft with sutures. So here I'm using subconjunctival BSS, and again to get a thin autograft here, which helps in this case. And then we are using interrupted atovicral sutures, taking the episcleral bites. So if we take the episcleral bites, this again prevents the ballooning of the graft. So typically we are using 2 sutures on either side of the limbus, and then we can use a couple of sutures on the conjunctival side as well. So advantages of using fibrin glue over sutures are mainly to shorten the surgical times. In a Cochrane review, it was found to be on an average 17 minutes lesser. And of course, the patient is more comfortable and we don't have any suture-related complications.
Last 1 minute.
Yeah. Surgical time is specifically important when we are dealing with combined surgery like pterygium and cataract, and also double-headed pterygia. The main disadvantage of using fibrin glue over sutures is that it is more expensive, and there's very low level of evidence to tell us that there might be higher chances of graft dehiscence. But graft dehiscence depends on various factors like preparation of the graft, the manipulation, the surgical experience, and eye rubbing by the patients. So this is my last slide. I'll just like to share a few surgical pearls to avoid these complications. First is to have a thin autograft. Then drying of the scleral bed before application of the glue. We don't have any hemorrhage or bleeding at that site, because otherwise that will again tend to balloon up the graft. And then we need to use this fibrin glue. Normally comes as a Diplojet injector, but that usually causes a lot of clumping. So here I'm using 2 1 ml syringes. On that the 26 gauge needle is mounted, which again gives us a very thin layer, and then ironing out the graft once we have secured it in position. A very important step that we should not forget is after we have done this is to trim the excess glue from the surface, because if we don't trim the glue and we just pull the speculum out or we just pull the glue out, that might dislodge the graft again. So this again is a very important step that we must not forget, and to educate the patients, of course, to avoid eye rubbing post-operatively. Thank you for your kind attention. I would like to thank all my mentors before I end my presentation. Thank you.
Yeah, thank you, Dr. Ikeda. It was a wonderful talk and also wonderful video you have shown. If there is any question, you can go to the next session by the meantime. Next session, yeah.
Ask at the end.
Next session, next speaker we have Dr. Monica Arora. She will be speaking on primary angle closure disease spectrum. Okay.
Good afternoon, everyone. A very sincere thank to Chief Sir and RPC for giving me such a wonderful opportunity. My topic is primary angle closure disease.
The slide, AV people are there. The slides are not running, please check.
So as we all know, classification of primary angle closure disease includes primary angle closure suspect at least 180 degree occludable angle, primary angle closure, goniosynechiae, peripheral anterior synechiae, synechial closure, along with signs of previous attack and with high IOP. Primary angle closures glaucoma includes synechial closure with elevated IOP with evident of optic nerve head changes with or without visual field changes. So I would like to discuss the management with 3 case scenario. Case 1, 41-year female with history of blurring of vision in right eye, which was sudden in onset after watching a play in a theatre, which was associated with headache, vomiting, colored halos, watering, redness, no systemic illness. Visual acuity in the right eye is 3/60 PR accurate, in the left eye 6/6. In the right eye, the IOP is 56 millimeter of mercury, whereas in left eye it is 16 millimeter of mercury. CCT seems to be normal. On examination, as we can see, the PI is not patent in right eye. There is corneal edema, circumcorneal congestion, vertically mid-dilated pupil, shallow AC, corneal edema, aqueous flare. And in the left eye, anterior segment seems to be normal, but it is shallow, 1 Herrick grade 1. And on gonioscopy, it reveals left eye occludable angles. And posterior segment seems to be normal with vertical CDR ratio of 0.41. So the diagnosis in the right eye is acute angle closure attack, and the left eye is the fellow eye. So coming to the management, as we know, acute angle closure attacks requires urgent lowering of the IOP with maximum tolerated medical therapy, and we have to rule out any secondary cause for the angle closure attack like phacomorphic glaucoma or NVG. And when the IOP is controlled, the augmentation of the iridotomy is required, taper medication and modify medication according to the diurnal control and optic nerve head changes. If the IOP is not controlled, the patient can be planned for trabeculectomy or phacotrabeculectomy depending upon the grade of the cataract. So we all know that primary angle closure suspects doesn't require PI in every cases, but if the patient is having a risk factors like fellow eye of acute angle closure attack, established PAC or PACG in fellow eye, family history of glaucoma, require frequent pupillary dilatation, can't come for follow-up. So in these cases, we have to go for the prophylactic PI. On follow-up, if the PI is patent, we can go for annually or biannually review of optic disc changes and visual field changes. So coming to case 2, a 47-year female, history of blurred vision in both eyes, no systemic illness, father has a glaucoma, visual acuity in the right eye is 6/9 improving to 6/6, and in left eye it is 6/18 improving to 6/6. IOP in the right eye is 16, whereas in left eye it is 20, and CCT appears to be normal. On DV, we have seen at 7 a.m., 1 p.m., 4 p.m. and 7 p.m. there is a spike of IOP. Anterior segment seems to be normal, but shallow. Right eye do not have the PI, and on gonioscopy, both the eyes have synechial closure. Optic disc seems to be normal. There were no visual field changes. The diagnosis is both eye PAC. So the management of PAC is PI, and we have to reassess IOP after PI. Coming to case 3, 50-year-old female, history of headache, diagnosed as glaucoma since 4 months. Baseline IOP is 24 and 38 in the left eye. Visual acuity in the right eye is 6/36, improving to 6/9. And in left eye it is 5/60, improving to 6/60, CCT normal. IOP at present is in the right eye is 18, and whereas on the left eye is 30. Patient is currently on 5 anti-glaucoma drugs. There is no PI in the right eye, whereas in the left eye, the anterior chamber is shallow, pupillary rough atrophy, sectoral iris atrophy. On gonioscopy, synechial closure, blotchy pigmentation. Optic nerve in the right eye is 0.8, whereas in left eye it is 0.9, with severe visual fields defects. The diagnosis is PACG. Management in the right eye, YAG PI and modification of medical therapy, whereas in the left eye we have to achieve a target pressure of 10 to 12. The patient can undergo for the trabeculectomy and phacoemulsification. So there are a few indications for the surgery. In our case, it is IOP not controlled despite maximum medical therapy, and there are few more indications: progression of visual field despite maximum medical therapy, poor compliance or drug allergy, socioeconomic factors, patient unable to follow up. So take-home message is, in primary angle closure suspect, we have to evaluate the risk factor and then we should go for the PI. In PAC, patient require both eye PI, whereas in PACG we have to set the target IOP with medical management or trabeculectomy or phacotrabeculectomy. Thank you.
Thank you, Dr. Monica. That was a wonderful talk covering PACS and PAC very comprehensively. And we'll take the questions in the end. I would now like to invite Dr. Neha Midha for a talk on micropulse laser therapy.
A very good afternoon, everybody, and thank you for inviting me here. So I'll be talking about the micropulse laser therapy, acknowledgement to my mentors. And so in our continuation to our quest of finding an ideal IOP lowering modality, micropulse is another kid on the block. So what is the basic mechanism of action? So micropulse basically acts by giving repetitive short pulses of 810 nanometer infrared diode laser in such a way that the coagulative threshold is achieved in the targeted pigmented epithelium, however, not causing much collateral damage to the surrounding tissues, thus decreasing the chances of inflammation and thysus bulbi in comparison to the conventional continuous wave transscleral photocoagulation. It is able to do so because the duty cycle in micropulse laser is such that the laser is being delivered only for 0.5 milliseconds in the on time, whereas the laser is switched off for the 1.1 milliseconds. Therefore, the heat energy accumulated is much less. There are other mechanism of actions also described, like pilocarpine-like effect, causing stretching of the trabecular meshwork and increasing the width of Schlemm's canal and increasing the uveoscleral outflow. However, these methods have not been proven. So basically, there are two types of micropulse laser that is currently available in the market. One is by the Iridex in the name of Cyclo G6, and other is by the name of Vitra, being manufactured by Quantil. There is slight difference in the probes of both the machines. With the Iridex, this is a purple color probe that you can see. It has a foot plate to be placed at the limbus, and then the energy will be delivered to the ciliary body. For the Quantil, for the continuous wave, you have to use with the foot plate. When you have to use the micropulse laser, you need to remove the foot plate and use the fiber optic probe directly over the sclera. So what are the indications? So when it was initially launched, it was being marketed as a primary treatment option, as a replacement of trabeculectomy. A lot of practitioners were doing this as a primary modality, but however, that is far from reality. In my personal experience, I have been using micropulse in cases like failed TRAB, in patients where the trabeculectomy is very high risk, but the visual potential is low, post-VR cases, post-PK, in pregnancy as an interim procedures, patient not willing for surgery and are intolerant to AGM. So the main key here is to do your good patient selection. It is a good modality provided it is used in the correct indication. So the procedure, so under local anesthesia, you have to use a viscoelastic agent or a lidocaine jelly so as to allow smooth sweeping movements. And the commonly used settings are 2000 milliwatt with 80 seconds per hemisphere or 40 seconds per quadrant. Identifying the ciliary body positions using illumination is crucial. So this is a short clip using the Iridex probe where you can see how the sweeping movements are done. Having a viscoelastic agent between is extremely important. And this is using the Quantil machine. Here, I usually mark 3 millimeters from the limbus in whatever quadrant or hemisphere I plan to do the treatment. And then we can do sweeping movements. Here we can see. So the main idea here, the procedure as such is not technically demanding or anything, but however, we need to keep in mind the concept of sweep velocity. Imagine there is a flame and you have to sweep your finger across. If I sweep my finger very fast from the flame, there are chances that I will not feel any heat. However, if I'm sweeping the finger too slow, there's a chances that I might get burned. So with expertise and as you do more and more, you realize that how much sweep velocity you have to maintain so as to achieve your desired results. So the eye is patched for 6 hours, topical antibiotic steroids and cycloplegics are given. Patient continues all anti-glaucoma medications till you see the drop in IOP and is gradually tapered off. So it is an efficacious technique, does give you about 20 to 25% reduction in IOP. However, you have to know that it is not completely safe. The study of 207 patients over 18 months follow-up, we had one eye of this study published in Journal of Glaucoma showed the one eye had hypotony, 7 eyes had phthisis bulbi, and 13% eyes had reduction in the visual acuity. Similarly here, you see about 15% of eyes lost more than 3 Snellen lines. So you have to be very cautious while doing this technique. Again, it can also damage the limbal neuroplexus and give rise to neurotrophic keratitis. So just to discuss my last case here, I did it on a 30-year-old female with a history of granulomatous uveitis, right eye uveitic glaucoma, failed TRAB, and maintaining 16 mm Hg on 3 bottles, 5 drugs, lost control intermittently, went up to 26, phakic patient, shallow AC, 360-degree pass. I am honestly was scared to do TRAB, and so was the patient. So I did inferior 180-degree treatment. I got a decent result, about 2 bottles, and patient was maintaining 16 millimeters of mercury. This was in Jan 2021. Now again, the patient has 6 weeks of amenorrhea. She has conceived, and now I planned a retreatment for her, and now currently she is drug-free and maintaining 18 millimeters of mercury. There's a small knowledge gap. We still don't know whether the sliding technique is better versus the traditional stationary technique. Titration of energy level still needs to be figured out. There is no audible or visual cue that exists, and it can result in increased complications. The mechanism for IOP reduction and the rationale claimed for better efficacy is also not very convincing. So there is a lack of data about this technique. That's it. Thank you.
Thank you, Neha, for the wonderful talk. So in the interest of time, I think I'll call the next speaker, Dr. Sandhya Mukhija, who would be speaking on how to give cataract surgery with coexisting DME.
Good afternoon, everyone, and congratulations to the RPC team for their 56th Foundation Day, and I thank the whole RP Center team for having me here, inviting me here. So now, in the session of Basics Redefined, I think this is quite an apt topic. We all do cataract surgeries, and we all do intravitreal therapies. So how is the idea, of combining both? So I'll be just discussing this aspect, when and how. Firstly, just to touch the basics, we all know diabetic macular edema is a common cause of visual loss, especially in patients with diabetic retinopathies. Of course, sorry, we are talking about diabetic macular edema. Cataract is more common in diabetics, 2 to 4 times higher risk, and it's one of the major cause of visual loss. Cataract surgery has been accused of causing rapid progression in severity of diabetic retinopathy, and especially macular edema, and a cause of poor post-op visual recovery. See, this is a diabetic retinopathy patient initially very early. The first picture shows very early diabetic retinopathy pre-surgery, and once the patient undergoes cataract surgery, and if we follow up a few months later, this is how the retinopathy progresses in the second and third picture, if you see. Intravitreal, whatever it is, anti-VEGF or dexamethasone implant is known to cause resolution of macular edemas and improvement in visual acuity, according to many studies. And the mechanism of DME involves a lot of mediators like inflammation. In fact, inflammatory mediators these days are also found to have key role. It's a combination of several different mechanisms, actually. There is alternation of drainage, inner retinal barrier breakdown, there is inflammation, there is age-related oxidative stress going on, there are systemic factors like duration, control, high blood pressure, other systemic associations, etc. And even outer retinal barrier breakdown also happens. There are various studies, and let me not go into the details, but the studies support inflammatory mediators and various VEGFs as a causative factor for edemas and retinopathies. If you talk about intravitreal steroids, basically it targets inflammation, and anti-VEGFs are targeting basically the VEGF mediators release. They both stabilize the junctions between endothelial cells in the retinal blood vessels. In fact, some studies have also shown effects of hard exudates. Studies have shown that hard exudates at times, they just melt away, especially after dexamethasone implant, some studies have shown. Some studies are against it also. So, just to touch various names of studies, Meehan, Mozart, and Schefflin and Plessis studies. So indication of, if we talk about steroids, there are specific indication. Anti-VEGF can be used in almost all the cases of DRs. But with steroids, what majority we all feel, pseudofakes with DME, they do well with intravitreal steroids. I mean, we would prefer to give them intravitreal steroids, maybe even as a first line sometimes. Phakic patient, if the patient you feel is non-compliant, it's difficult to follow up, they're not coming again because of their long-term effect. Phakic patients with center involving maybe macular edema, maybe with hard exudates, maybe with we would like to go in with a steroid implant. So now this theory apart, now if we see a diabetic person, a diabetic patient, if we think his profile, the disease itself is associated with a lot of other morbidities, comorbidities involving other body systems. He has to pay lots of visits to other physicians, specialists, not even ophthalmologists, but other specialists also. There is financial burden to the patient, family, and everyone around him. To add, there is visual handicap associated with cataract, for which he would need a surgical treatment soon. So this is something like a calendar of a diabetic patient, you know, full of visits for various doctors, nephro, endocrino, ophthal, this, that, and so many treatments and revisits and pathological tests and everything. So patient is burdened both psychologically as well as financially. And more than that, if he has cataract, he has a DME, he has to undergo multiple injections and surgical treatments and everything. So why not treat in one go? Combine cataract surgery with intravitreal therapies, whatever drug you want to choose, and give him a better visual outcome and better psychological rehabilitation also. It's not a bad idea. So what are the rules? One has to go in for good metabolic control. Complete anterior and posterior segment workup has to be done. Dilate and examine both eyes, and if need be, do an FFA, OCT, even if it's better to document, B-scan if needed, if visualization is bad. So must do a preoperative OCTs. You might find something like surprise, like a vitreomacular traction, which might not be treatable with just an injection. So if one plans to treat DME along with cataract surgery, there are studies, and okay, I think there's less of time, so I'll just go further. Surgical considerations, good patient counseling, diabetic status should be well controlled, good surgeries, superior or supratemporal clear corneal incision, avoid any PC rupture, any lens iris touch, vitreous adhesion, because post-op CME is more common in such cases. Emphasize on minimal corneal damage. Corneal epithelium is slow to heal in such patients. Good phaco with in-the-back IOL, large optic IOL, special care against end-off, and then at the end, one can go in for a injection, intravitreal injection. So I'll just summarize. Intravitreal anti-VEGF or steroid can be a good choice in DME, especially when cataract surgery is also being planned. It circumvents multiple injections and multiple surgeries. So I would just like to show you a few cases where we did combined procedures. So this was the preoperative patient, this kind of macular edema. So we implanted Ozurdex as well as combined this case with cataract surgery. 3-month post-operative, the patient was pretty satisfied because cataract also gone and edema started resolving. And another case again, this is a post-operative picture actually. And after 3 months, the same case has maintained a good visual acuity after 3 months. Another case where this patient was a laser proliferative diabetic retinopathy with DME with cataract. Again, we implanted Ozurdex along with the cataract surgery. And these are the post-operative OCTs in the right eye. Left eye, also the patient has cataract with the macular edema. 3 months after he started developing some ERM, some foveal inversion was there, but at least there was no macular edema. Thank you.
Thank you, ma'am, for such a concise talk. Ma'am, did you face any complications?
No, thankfully in our cases we didn't face any complication. But of course one has to be careful, yes.
Okay. Thank you.
Okay, thank you. So moving on to the next speaker, we have Dr. Parikshit Gogate. He will be speaking on how to give 6 and 6 vision unaided after phaco surgery.
Is there a pointer? Yes. Respected chairpersons, distinguished audience, I'll be speaking on how to give 6/6 and 6 vision after cataract surgery. Well, we all know cataract is the refractive surgery. This is the prescription that we would be giving when I did my residency in the mid-1990s. Now, this has gone because of the IOL. This has gone because of phaco and SICS. And the addition has gone because of the multifocal lenses. But surgery is not just by hands, it is also in the mind. Good surgical skill is necessary, but is not a sufficient condition for a good surgical outcome. The planning and proper execution are also a must. So for that, we need a very good preoperative workup, and immersion A-scan or ultrasound biometry and optical biometry is a must. And there are so many gadgets which help us diagnose comorbidities which we can tell the patient beforehand. There has to be proper pre- and intraoperative care. Intraoperatively, there is a whole revolution that has happened in OVDs, pupil expanders, capsule tension rings. So while accurate IOL park calculation is a must, a proper accurate IOL placement is also needed. And for this, we have to understand pre-existing astigmatism and we have to neutralize it. And there are various ways of doing it. One, of course, is taking the incision on the steeper meridian, knowing your surgically induced astigmatism. Nowadays, we have toric IOLs, but even larger planned incisions in SICS can help. And there is, of course, limbal relaxing incisions, femto-assisted corneal cuts. There is so much that we can choose for. And it's not just pre-op and intra-op. We also have to look at the post-op surprises, edema, iris injury, inflammation, PCRs, decentration of IOLs. But in this, we have to finally first understand what does the patient want. Some patients, like embroidery makers, watchmakers, goldsmiths, bibliophiles, they want better unaided near vision. But most people, drivers, travelers, marketing people, hawkers, pilots, policemen, they all want good unaided distant vision. And there are some, like our computer geeks, chefs, painters, musicians, who want better unaided intermediate vision. So we have to understand first what it is that the patient wants before we recommend the technique and the lens to that patient. And what is also important is how much is the patient's budget? What is his willingness to spend? Ability to spend is one thing, willingness to spend is another thing. So trifocal and high-end EDOFs are the best, but many patients are not able or even willing to afford perhaps a Zeiss Acrylisa, a Alcon Vivity, or a Technis Synergy, all of them excellent lenses. So what else can we offer them? We can offer them monovision, mix and match, with one eye distant dominant, the other eye near dominant. There is smart SICS by which we can give almost 6/9 N8 unaided vision. Or this is what we would be doing in our medical college days. We just make the residual error -1 so that they can do most of their stuff without spectacles. So the surgeon has to choose the technique and the IOL and guide the patient towards it. So phaco is definitely best, but especially so for infants, children, young adult cataracts, softer cataracts, immature cataracts, subluxated lenses. SICS can be chosen for very hard cataracts, lens-induced glaucomas, compromised corneas, chronic uveitis. So like in SICS, we can center it on the steeper meridian. And because we have almost nearly 180 degrees to choose from, and if we do that well, even a high astigmatism like this, -3 diopters, can be completely neutralized by SICS. Even multifocal implants can be put in properly. In fact, if there is a high astigmatism, we can put in a multifocal IOL without using a toric. Because if we have a large high astigmatism, and suppose we take this large straight superior-nasal incision, we can completely neutralize it and we can have a cornea that is giving patient a 6/6, almost N6 vision. So it is not just surgically induced astigmatism, it can also be surgically corrected astigmatism. So we have a customized incision cataract surgery that Dr. Boramani propounds. But finally, when we are talking to a patient, we have to promise less and deliver more. So if 6/9 N8 is promised and delivered, patient is happy. But if 6/6 N6 is delivered, patient is happier. And while doing this, well, we have to respect biology, because sterilization and asepsis, not even 1% compromise, because what may go wrong will always go wrong. Sutures can still be our saviors, and we need a regular and a complete follow-up, irrespective of how good our surgical skill is, because finally that is the vision that the patient goes on with. So once more, I would like to thank the RP Center, Chief Professor Titiyal, Professor Namrata, for giving me this invitation. Thank you. Thank you, chairs.
Thank you, sir, for the wonderful talk. And next, I would like to call upon Dr. Mudit Tyagi. He would be speaking on fibrin glue-assisted surgeries in rhegmatogenous retinal detachments.
All right, so good afternoon, and first of all, let me thank the chairs and the team at RP Center for giving me a chance to talk on our work on fibrin glue-assisted retinopexy for rhegmatogenous retinal detachments. Now, we all know that the conventional surgical management for a retinal detachment includes either a scleral buckling or a vitrectomy or a pneumatic retinopexy. Now, with improving instrumentation and with changing times, vitrectomies are becoming more and more common for taking care of a lot of these RDs. However, what we also know is that there are problems with the conventional tamponades that we use in RD cases. You need to give all your patient post-operative positioning. There is always a chance of glaucoma, corneal changes, and cataract. Apart from that, there is a risk of hypotony once you remove the oil. There is a delayed visual recovery till the time you remove the oil or till the time the gas bubble dissipates, and a restriction in air travel whenever we inject gas in most of our patients. We also need to understand, if you look at the pathology, adhesion strength of almost 90% or more is achieved at 18 hours after a laser photocoagulation. And a maximum strength is reached around day 5. So you essentially need a tamponade agent only till the time a retinopexy effect comes, which means maximum 4 to 5 days. So if we go back and look at what does the tamponade agent do, a tamponade, the etymology, the word comes from the word tampon, which means to plug. And essentially in RD surgeries, tamponade agents are used to provide surface tension across breaks in order to prevent further fluid from going back into subretinal space till the time the effect of retinopexy, which may be a photocoagulation by laser or a cryo, becomes permanent. So we went back and started thinking, can we do something else? Can we use some other agent for a tamponade instead of oil or gas? Now fibrin glue becomes a likely candidate. It's a mixture of aprotinin, fibronectin, and plasminogen. Has already been used in ophthalmology for ocular surface procedures, for scleral fixation, has actually even been used in retina in optic disc with associated macular detachments. Fortunately for us also, already a lot of studies have been done which have studied the safety of fibrin glue inside the eye, and we already know at this point of time that fibrin glue is not toxic to the retina or to the RPE. Animal experiments have already proven that it is non-toxic agent. So we have a non-toxic agent which has already been used in ophthalmology, even in retina earlier, and therefore we decided to explore its role in a tamponade for RD surgeries. So this was the study which we did, which is glue-assisted retinopexy for rhegmatogenous retinal detachments. We came up with a name for the technique called GUARD study. For this, we excluded all patients who were less than 18 years of age, any past history of retinal surgery, giant retinal tears, PVR grade C or more, detachments associated with vitreous hemorrhage, choroidal detachments, or detachments with an associated macular hole were excluded initially. And we published pilot study results of our initial 10 patients in IGO earlier. But if you look at the surgical technique essentially is pretty similar to what we do otherwise. So you have got a patient with a detachment, you do a complete vitrectomy, do a fluid air exchange, settle the retina, do a laser around the break. But after this point, after doing a laser, now instead of putting oil or gas, what we do is we put a small drop of fibrin glue over the break, so as to essentially cover the break with just a fibrin glue coagulum. Most importantly, no postoperative positioning needs to be given for any of these patients. Now fibrin glue comes in two components, a thick and a thin component. What we do is we put a drop of thick component first, followed by a drop of thin component. The reason is that if you put a thick component first, it prevents a subretinal migration of fibrin glue to some extent. So this was one of our patients who came up with a vision of 20/500 to our clinics over here, and this is how the surgery is. So in the interest of time, I'll just skip the initial steps, but initially it involves doing a complete vitrectomy, which is what you can see we are doing over here. You do a complete vitrectomy, remove the entire vitreous, search for the break. So there was one superior break over here. And after doing a fluid air exchange, settling the retina and doing a laser, what you need to do is that you put a drop, this is a complete fluid air exchange, a drop of fibrin glue over the coagulum. So you put one drop of thick component over both the breaks, followed by a drop of fibrin glue, a thin component. And then in an air-filled globe, you just wait for around 2 to 3 minutes. In 3 minutes, a coagulum forms, and all you need to do is just lift the coagulum. You can use your flute needle or even a forceps to just lift it and deposit it and cover it over the break. That's all you need to do. So you have covered the break with a coagulum over here. The same you can do over here for the superior break also, where you use the forceps to just cover the break with a fibrin coagulum. And this is how the patient was on the first post-operative. There was small air bubble which was left behind, but you can see this coagulum covering the break over here. And at 1 week, the entire fibrin glue has gone away. You see an attached retina with surrounding laser marks. Another video where I just want to basically show how easy it is to deposit the fibrin glue over here. That video is not playing, but anyways. So this was one of our patients. Again, you can see a fibrin glue coagulum covering the break on the first post-operative day, and in week 10 or 2 weeks, the entire fibrin glue coagulum dissipates and gets absorbed spontaneously. So this is how the evolution occurs. Preoperatively, you see an RD, day 1 a fibrin coagulum, and in 2 weeks, the entire coagulum goes away, leaving an attached retina. So you see patients where you don't need to put oil, you don't need to put gas, you get an early visual rehabilitation within a span of 8 to 10 days. So our primary outcome was to look at successful attachment, and secondary outcome measures were to look at improvement in visual acuity and any further complications. So what we found was, and we have now done it in more than 50 patients, and the visual acuity improved from 20/200 at baseline to 20/80 at 1 week, and at 1 month it was 20/50, which was maintained till the day of the last follow-up also. So this was one more of our patients where you can see an inferior RD. This patient also had a vasculitis and an inferior temporal quadrant break. This is how the patient was on the first post-operative day with a fibrin coagulum covering the break. And I have a minute, I believe. Yeah. And this is how the patient is at 10 days, where you can see the entire coagulum totally absorbed and an attached retina with surrounding laser marks. Another patient preoperatively, post-operative day 1, we have just left the eye under fluid itself. We even removed the air. Intraoperatively, you see a fibrin coagulum covering the break. 1 week, the coagulum is nearly gone away, and this is at 2 weeks, where you see an attached retina, vision 20/60. And in none of these patients did we need to give any post-operative positioning. 2 of our eyes had increased post-operative inflammation, but that could just be managed by just increasing the frequency of topical steroids the next day. Some of these cases may have a minimal subretinal glue migration. This is what you can see over here. But this is a protein. In the span of just 1 week, this entire thing gets absorbed. This was one of our initial cases actually, and you can see amount of fibrin which is too excessive. This was the second case which we ever did. But within a span of 2 weeks, that entire excessive coagulum also has gone away, leaving behind an attached retina. 5 of our cases showed a cystoid macular edema, but this just went away with topical Nepafinac eye drops. 3 of these patients had an ACIL and a complicated cataract surgery earlier. So in a nutshell, tamponade agents are used to provide surface tension across breaks in order to prevent further fluid flow into subretinal space till the effect of the retinopexy becomes permanent, and we believe that fibrin glue has the capability of acting as an effective tamponade and can help us in obviating the need for silicone oil as well as gas, as well as giving post-operative positioning and allowing us for an early visual recovery. Thank you so much. Just one brief moment for the relative contraindications. Extremely large breaks will not be amenable to this surgery because you will have a subretinal migration of the glue in these cases. Anteriorly placed breaks, again a contraindication. This is not a technique which is a substitute for scleral buckle. If you have a break which is extremely anterior, ideally you should go ahead and do a buckle. This is a technique which is a replacement for tamponades. So when you are doing a vitrectomy, this is a technique as a substitute for silicone oil or gas. But in anteriorly placed breaks, go ahead with a buckling. And large multiple breaks again becomes a problem because the fibrin coagulum tends to get adherent to each other. But apart from that, it's a good technique which allows early rehabilitation in simple RDs. Thank you so much. And I would just like to acknowledge my team and my colleagues who have been with me for this technique. Thank you so much.
Thank you, Dr. Mudit, for the wonderful talk and the wonderful video. So just one quick question that have you tried it in breaks in which there is some amount of fluid residual behind the retina and still the coagulum forms, or it doesn't form?
No, so you do it under an air-filled globe. So once you have done a fluid air exchange, you have anyways completely dried the area around it. You have removed the entire fluid. That's how only after that will you be able to do a laser around the breaks. So once you have done a complete fluid air exchange, settled the retina, done a laser around it, after that in an air-filled globe you put a drop of fibrin glue and you wait for 2 to 3 minutes for the coagulum to form. And after that you can just deposit it back over
In
the
case
brain.
there is some fluid left, will it still form the coagulum, or
If there is some fluid left, it will still form a coagulum, but the problem is if there is some fluid left, then your chances of a subretinal migration of your glue becomes much higher. And that will probably prevent a successful attachment. So you have to ensure that the entire area is fluid free. All right, thank you.
Small question. Excellent video, Mudit. So one thing, so when you do air fluid exchange, you have put the coagulum over the break. So then you remove the air or you let it be there?
So earlier I was just letting the air be, but then there are a lot of things when people say that is it the air that is working, but then we are not giving any positioning. So air anyways would not work. But as a proof of concept, we have now started removing air also, and even after removing air, the coagulum stays at the place. So the video, the last case which I had shown, the multiple images, both of these cases we have removed air completely just to see whether it's still working even without air or not, and it works.
In fact, that's why I asked that.
Yeah.
Because you have removed the air.
Yeah, so I removed it just to see whether it works even after removing air, and it works even then.
Take the questions maybe a little later.
Yes,
We
it
are
stays even.
just-
Once we have put it for after 3 minutes, it just takes over there.
In
It
the
doesn't move
meantime, we
around.
can have Dr. Vinod sir ready with his presentation, and Dr. Vinod will be speaking on how to tackle secondary macular holes.
So you don't have to rotate it. It's a liquid. It anyways will float. And if you saw the video, it floats, moves around a little bit. But you can just lift it like a coagulum, lift it and put it back in place. You don't have to make it more. You don't have to do anything. Even if you do, it will still trickle out somewhere around here. It's a liquid. That's how it's a propensity of a liquid. It will flow and spread around. What you can do is after that you just lift it easily. If you saw the video, it's very easy to lift. You just use a forceps or even your flute. Lift it. I'm so sorry. I thought I'm loud enough even otherwise. But yeah, you just have to lift it and put it back over the break. That's it. Okay. Thank you.
Thank you, Mudit. After a thought-provoking talk, I'll be talking about tackling secondary macular holes. Nothing novel in it. The idea is just to share with you all some of my unusual cases which I've come across through these several years. We know that idiopathic full thickness macular holes are a problem of basically VR interface, and all the secondary macular holes or the so-called atypical macular holes are a result of other retinal pathology. Because of better imaging modalities, they are more commonly recognized, and because we want to treat all the macular holes, I think we are seeing more and more of them. And at times, these secondary macular holes may pose a diagnostic and a therapeutic dilemma. So coming straight to some of my cases. So the first case is of a 25-year-old male who presented to us with decrease of vision in his left eye for past 2 weeks. The patient had a trauma with firecrackers. He presented with visual acuity of 2200 in the left eye. While the anterior segment was normal in both the eyes, the left eye showed a full thickness macular hole, a large subretinal bleed, and a choroidal rupture somewhere here, and you can see that subretinal bleed is there on OCT scans as well. In addition, patient showed inferior vitreous hemorrhage, though the retinal periphery was normal. So there could be several scenarios in such a patient. One may traditionally choose to do a 2-stage surgery where you put intravitreal gas plus minus TPA, and then it is followed by prone position, and once the hemorrhage resolves, then one can go ahead with macular hole surgery. It offers the advantage of being more controlled procedures, but has the disadvantage of that patient has to undergo 2 procedures, and of course there is a delay in macular hole surgery, which may decrease the final visual acuity which can be obtained by the patient. So another approach to such patient is simultaneous macular hole surgery and removal of blood. That is what I tried in this particular patient. It had the advantage of quicker and early recovery, and of course 1-stage procedure tends to be definitely more effective. So this is this small video of this particular patient. After the initial vitrectomy, PVD was already complete. So what I did was I checked the PVD with the help of triamcinolone. Then I completed my air fluid exchange, and since the bleed was 2 weeks old, so I decided to inject TPA through the hole itself into the subretinal space. You can see some amount of blood coming. Then I let the TPA be there, and meanwhile I thought I'll complete my ILM peeling. So you can see with the help of IOCT, there's some blood still underneath the macular hole. You can see otherwise also. A conventional ILM peeling was completed. I'll skip that in interest of time. Once the hole was, ILM was peeled, so what I did is went with a small gauge soft tip cannula and just put it next to the hole, and to my surprise all the blood came out very nicely. And at the end of the surgery, all I did was did a repeat air fluid exchange and left it under SF6 gas. So this is 3 weeks post-operatively. You can see there is a choroidal rupture which can be seen very nicely now. The hole has closed. There is some extra macular submacular bleed still there, which we are not worried about, because it is going to resolve over a period of time. This is the OCT. You can see the hole has closed nicely with nice contour, though EZ is not continuous at this moment. And this is 3 months down the line. You can see the hole has closed nicely. EZ and ELM both are becoming normalized, and this patient had an excellent gain in visual acuity. So the idea is just to present a few more cases. Another patient with PDR, you can see florid proliferation, and patient has VMTS. The patient did not had a good metabolic control at this stage. So in spite of VMTS, we went ahead with PRP, and this patient landed up with a full thickness macular hole, for which the patient was operated, and at 3 months patient had a nice type 1 closure and with good gain in visual acuity. This is a patient with young male who presented to us with decrease in vision in both the eyes. So if you see, there is a macular hole in the right eye along with some schisis, and schisis in the other eye confirmed that we were dealing with a patient with X-linked retinoschisis. This patient again underwent surgery under guarded visual prognosis. You can see the hole has closed nicely, and what you can see is also a very prominent downfall appearance in this eye. The hole had closed, and to our surprise, the schisis also decreased because of the topical dorzolamide. We had subsequently similar cases of large full thickness macular hole in X-linked retinoschisis, which we undertook surgery. This was a very large hole which did not close fully, but the hole decreased in size, and the patient had a gain of vision, though only very small gain of 1 line only. So another patient, you can see there is a small full thickness macular hole, but it is sitting over a choroidal lesion. You can see this is a choroidal hemangioma which is there in the choroid. You can see the choroidal flush on ICG angiography in these patients. Again, this patient had been denied surgery by several retinal surgeons. So after informed consent, he agreed to undergo surgery, and this was the result, and the patient was extremely happy. So I'll skip this particular patient in interest of time. This is my last case. You can see a young female who presented to us with decrease of vision. There was a full thickness macular hole, but what you can also see that there is a disc edema. Now that is something a little unusual, but what was surprising, that disc edema was seen in the other eye as well. So we just went on to screen the periphery of this patient, and you can see that there is a cysticercus in the inferior vitreous cavity, which had come into the vitreous cavity through the foveal area. So this patient had evidence of neurocysticercosis, and after appropriate neurological consultation, the patient underwent surgery. The hole closed, but the vision failed to improve in this particular patient. So to conclude, macular hole can be a presenting feature of several retinal disorders. Thorough fundus examination is must to reach a final diagnosis. I think surgery is the routine as we do in primary idiopathic holes, but the outcomes can vary in certain situations depending on the primary cause of the hole. Thank you. Thank you very much. Sir, glue has been tried by few authors. I think Mudit would be the best person to answer that if he wants to answer. Okay, Mudit.
So we are trying the use of fibrin glue in macular holes also. We have actually submitted our results for fibrin glue in macular holes, and it is working well in some cases, but our results are not as consistent as what we are finding with retinal detachment. Like for RD, if I've done it and used glue, I'm pretty assured that this is the outcome which is going to be. But for macular holes, I think we're still missing out on something, and it's not as consistent. We've tried it in 1 or 2 failed cases also, but the results are, it's working in some, it's not working in others. So I probably don't have a right answer right now, but maybe in few months I'll have an answer as to how we can use glue better.
I think so, if I can add to that, while in peripheral holes, the primary aim is to close the hole and create scarring. In macular holes, we don't want that to happen. So we want that retinal tissue should come only and plug that gap. So we have to devise strategies to bring the foveal tissue inside so that that can join. And I think our current techniques are quite effective for that matter, and that's why probably fibrin glue for macular hole is not going to be the future. That is my personal.
It's not. The only place probably where fibrin glue can be used as a substitute is old patients, one with spinal problems, or anybody who is not able to maintain a prone positioning.
Themselves.
But apart from that, others I don't think so. Our current techniques are good enough otherwise.
Okay, thanks a lot. Next, I would like to call upon Professor Bhavna Chawla.
Yeah. Again, because we know that subretinal blood causes a lot of shearing forces on photoreceptors, so glue going underneath the retina again can be counterproductive in such a case.
So next, we would like to call upon Professor Bhavna Chawla, who would be speaking on extraocular retinoblastoma, lessons learned.
Okay, thank you very much. So I'm really delighted to be here for multiple reasons, of course. Firstly, it's very nice to be batting on home turf, nothing like that. Secondly, I'm speaking on a topic which is very close to my heart, and that is retinoblastoma. And most importantly, I'm learning so much from all the fantastic presentations that have just taken place. So thank you. And I'll just be sharing my experience of almost 2 decades over how we have been managing extraocular retinoblastoma. So as we all know, as far as retinoblastoma is concerned, the first and foremost goal is to save the life, followed by saving the eyes, and wherever possible, save vision. Now, the first lesson that we learned was through this publication that we had in the British Journal of Ophthalmology a few years ago on the clinical presentation of survival of RB in Indian children. So what this basically showed us that extraocular retinoblastoma is something that we have to take very seriously because it is quite common in our part of the world. In this series of 600 patients, we found that at the presentation itself, more than 1/4 of patients had extraocular masses. Not only in India, but if you see in entire Asia, 43% of the global burden of retinoblastoma lies in Asia alone. So obviously, it is very important. The treatments that we are administering to our patients here in India has an impact not only in Asia, but all over the world. Now, extraocular retinoblastoma, as we understand, is a major contributor to mortality. Once the tumor spreads beyond the globe, the chances of metastasis and death is much higher than when it is confined just to the globe. So most often than not, children with extraocular presentation, retinoblastoma present with proptosis. There can be other signs like pain, redness. Sometimes there's also leukocoria. There might be a staphylomatous mass. In more advanced cases, we have a fungating mass, and sometimes they also have local regional lymph node spread. So first and foremost, whenever we suspect a diagnosis of extraocular retinoblastoma, we want to confirm it with imaging, and neuroimaging is the most important modality that comes to our rescue. So we go ahead and advise a contrast MRI of the orbits and brain. It helps us to confirm the diagnosis, defines the local extent of disease within the orbit, and also it is indicated because it helps in detection of trilateral retinoblastoma, which although rare, can also be a possibility. Then we need to help from our pediatric oncology colleagues because the child would need a metastatic workup and in the form of blood biochemistry, ultrasound abdomen, chest x-ray, bone marrow biopsy, CSF examination. They also usually do a whole body bone scan and sometimes also go for a whole body PET CT to look for any distant spread. Now, as far as management of extraocular retinoblastoma, an important lesson that we have learned is that multimodal approach can significantly improve survival outcomes in these patients. And what we mean by multimodal therapy is that we are using a combination of neoadjuvant chemotherapy, enucleation, and radiation therapy to the orbit to treat these patients. So this is the International Retinoblastoma Staging System that we follow, and stage 3 are the cases with local orbital spread, and stage 4 are cases with metastatic disease. So this was a landmark paper that our group published in the Ophthalmology Journal a few years ago, where we did a randomized study for extraocular retinoblastoma. It was the first randomized study of extraocular retinoblastoma done in the world, where we compared 2 chemotherapy protocols just to see which one is doing better. So what essentially we did here was that we used 2 different chemotherapy protocols, of course, of different drugs. So the first group had a 3-drug cycle and the second group had a 5-drug cycle, and we used the first protocol for 12 cycles, the second for 8 cycles. And here, when we compared group A versus group B, what we found that at 1 year, the survival was more or less the same for both groups of patients, but at 4 years it was significantly better for the group A patients, that is those that were treated with a 3-drug chemotherapy protocol. So this is an example of a patient who was treated in this manner. So what we actually do is that when the child comes to us with these large fungating masses, most of the times they're just referred to RP center from other centers. So we treat them with chemotherapy, give about 3 to 6 cycles of chemotherapy, repeat the MRI, and here you can see on the right hand side, majority of these cases show a dramatic response to the tumor, and then we can go ahead with a form of enucleation. So after we surgically remove the globe, then we treat further with radiation therapy and up to a total 12 cycles of chemotherapy. Now what happens when the tumor is already spread into the local lymph node? So this is again a case of stage 3B tumor. He was a patient from Bihar. He had come all the way, and most of the times we find that when children come from far off places, they come to us in very advanced stages, and some of them come in these kind of forms. So this again child we subjected to this multimodal protocol. You can see here that there is a big orbital mass, optic nerve thickening right up to the orbital apex on MRI, again showing preauricular and cervical lymph node enlargement, and this is what the child looked after chemotherapy. So these are really encouraging results, and it sort of gives us the motivation to treat these children. Now coming to stage 4 metastatic disease, once there is already bone marrow spread, then the prognosis obviously worsens, but still now we have started doing autologous stem cell transplantation at AIIMS, which is helping survival in children with bone marrow metastasis. 2 cases have been done in last 2 years, and so far they're both in remission. This is an example to show how a child with bone marrow metastasis was helped with autologous stem cell transplantation. This is the MRI. You can see such a large, huge mass in the right maxillary sinus, causing destruction of the maxillary bone, and not just the maxilla. If you look at the whole body PET CT, there was also an increased uptake in the proximal shaft of the femur and the L3 vertebra. So clearly a case of bone marrow metastasis. Treated with autologous stem cell transplantation, post 1 year, PET CT showed no metabolically active lesion. Of course, these children require very close follow-up and surveillance, because we always know that there is a chance of relapse. Long-term follow-up for extraocular retinoblastoma has been pretty good. All these cases that have been successfully treated, they do well long-term as well. For instance, this is a child, he had extraocular retinoblastoma at presentation, the other eye was normal. He was treated with this multimodal protocol. 7 years later, the MRI is showing there's a nice prosthesis over here, clean orbit, and the optic nerves are normal. Even the optic chiasma is normal. Challenges still remain, especially in the form of stage 4B, where there is intracranial extension or the CSF is positive. Intrathecal methotrexate and other anti-cancer therapies have been tried, but the results have not been that encouraging. So now the whole world has come together. We have just published the Global Retinoblastoma Presentation and Analysis Study in JAMA Oncology a couple of years ago. Here, 143 countries came together with their data and pulled together and published this paper. And the main result of this paper was that given that retinoblastoma is curable, the data that is coming from countries, the developing countries, that is concerning, and a lot has to be done in terms of awareness, and this mandates intervention at both national and international levels. So before I end, I want to thank the RP Center and the whole team that is working together for these patients. I'm deeply grateful to everyone, and most of all to our patients who have given us the greatest honor to continually learn. Thank you.
Thank you, ma'am, for the wonderful for your wonderful talk and your experience over 2 decades, and just concising it to just 7 minutes. Thanks a lot for that. So next, I would like to call upon Dr. B.S. Goyal, who would be speaking on learning through AIMS, a reminiscence.
Well, friends, this is really not a technical lecture as we have heard from Vinod and others. They were very illuminating. I am here only to share some of the experiences and advice to you as to how I have learned, as to how you have learned, or rather you can learn it. And it is a sort of a reminiscence of my stay at the All India Institute of Medical Sciences. Now, a visit to your school or your alma mater gives you many back memories, and which you have normally forgotten. And today I think this is the freshest memory which I have got it from AIMS today before you. Now this is the time my association goes to the All India Institute almost 60 years ago in 1963 when Professor Agarwal was visiting Patiala and I was doing my house job. As an examiner he was there. He spotted me and he said, "Will you like to come to me for a post-graduation?" And I think it was a wonderful experience and a wonderful suggestion to get it from him. And I would say, "Ke andha kya mange dono aankhein." And it was immediately yes to him that I would. But he had put one condition, that you have to come there and stay for 3 weeks or so. If you can work from 8 a.m. to 10 p.m. with no break, no holiday in between. And I think I passed that test and he admitted me there in the All India Institute. And I was greatly relieved of doing my post-graduation with Professor Agarwal at the Institute of Ophthalmology before RP Center came into it. My colleagues were Dr. Gehlot, I don't know if any of you have heard, and Dr. Radha Natarajan from Lady Harding. Both of them are deceased now. We were batchmates. And in the senior, I had Dr. Angra, Dr. Lamba, and others as my senior colleagues, and Dr. Dada, Dr. Hare, and some others as our junior colleagues in the same batch. And that learning started together. Our teachers, Professor Khosla, Dr. Madan Mohan, Vaidiyal, R.K. Batta, most of them you are saying are deceased. I pay my homage to them. But we learned together from our registrars. N.N. Sood was our registrar, A.K. Gupta was our registrar, P.K. Agarwal was our registrar. And not only the registrars were grinding us through thick and thin, almost whole day and in the evening discussions in the ward, and along with some seniors as well as juniors. So it is a sort of group learning which we had it, and I'm sure it is continuing even now, that we were compulsorily supposed to hold seminars and discuss it in the evening before it was presented the next day. So that was a group learning which we had. And in fact, we had a very good social interaction. We used to have coffee pe charcha once in a month at the residence of Dr. L.P. Agarwal, along with dinners outside. He liked to go outside, and some picnics also. So we enjoyed picnics. A full bus load of the institute will take us to the picnic and forget for one day his rebukes and the discipline which he had in the department. So that was his, I would say, a great thing that is. Now I am reminded of one instance that once he was going back to Patiala as an examiner. He said, "You have to accompany me. I am going to complain against you to my father." And you can imagine my fate and my nervousness when I sat in his car, back seat of the car, with a halt in Chandigarh and then to Patiala, and I timidly asked my father to go and hear on my behalf the rebuke. Later on, my father said, no, 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 he never talked about you. Absolutely no talk about you. And it was such a big relief. And even he asked me to stay on for 2 to 3 days when leave to postgraduates at that time was unknown. I don't know what is the situation now. We were not given leave. Only the person who was getting married was allowed to get 2 days leave, that's all. P.K. Agarwal got married during that time. A.K. Gupta got married during that time. We attended their marriages. Now, the thing is as to how we can continue our learning. Now, I had been learning through RP Center by attending Foundation Day celebrations, getting academic upgrades. Even now I am attending, most of them I am attending. And you can upgrade yourself from the lectures, from the else, very well. And I would wish that all of you do continue to that as far as possible. Now, one thing unique about RP Center at the moment is that most of the postgraduates who have qualified from here, say I have been visiting several institutions in the country and abroad, where I find that many postgraduates are holding high office in their institutions, and they are helping to improve their improvement. And in most of the eye hospitals also, RP students are managing their status, and they are providing excellent health care to the public at large. Now, RP Center has excelled in several subspecialties. We also tried to develop subspecialties in my center in Aligarh, because I left as soon as I passed and joined Aligarh and continued throughout. It was Professor Agarwal's efforts to create subspecialties in our institution, and you would be wondering, he almost took a delegation of 30 MPs to Aligarh to visit the institution to sanction us new posts and upgrade that. And he helped countrywide to upgrade many institutions into regional institutes of ophthalmology, where they are providing great service and human effort to the people. Now, he also had at that time, I don't know if it is existing, Vinod will be able to tell us, we had an exchange program with RP Center. Our students were coming here for 2 weeks, almost twice a year on rotation, along with a teacher, and some of the students from here were going there to learn mass surgery as we were doing there. Is it existing something like that now? No, it is not. It is not. So that was a great help of the RP Center at that time to upgrade other centers in their teaching methodology. The other thing which I had noticed was the examiners which we went from here, Dr. Khosla, Dr. A.K. Gupta, and others, Dr. Sood, they came as examiners to us in Aligarh. Now, their expectations were higher because of their status here. And our subsequent examinations, we upgraded our teaching methods in a way that we stood up to them. So this is how we had been trying to learn from my teachers, from my colleagues. Say, N.N. Sood was there several times, Khosla was there, A.K. Gupta was there, Professor Agarwal, of course, was the mentor. He always had this. And reciprocally, say, I had been here as an examiner for postgraduates for several years during Dr. Khosla, with Dada, with Prem Prakash and others, and we helped a lot. Now, in nutshell, I would just like to say that once you pass out, do not break your ties with your alma mater. You will always continue to learn. And to tell you the truth, I am even learning today. There are so many things which we didn't know at that time. They didn't exist at that time, but now they exist and I come to know. Say like glue. I never knew about this glue. I had been doing retina in my days. I had been doing glaucoma in my days. Of course, my super specialty was strabismus. People know with strabismus most of the time. So these things that you can always learn. So I will advise my younger students and younger postgraduates to continue your association with your alma mater and continue to learn as you grow, and that will always keep you upgraded. Fine. Thank you very much.
Thank you, sir. Thank you, sir, for giving such a wonderful suggestion to all our residents. And with this, I think we can conclude our session. We can all come for all the speakers, and I think all the residents come for a photograph.
If there are any questions, ma'am, you can take up. If you definitely, yes, certainly.
I'll be a misfit here. No, you won't be. Height is higher than you. Yes. Thank you. Hard examiner? I passed over. Passed over. Because people consider me very hard, but I never tried to fail in
Okay. All right. So thank you, everyone. Thank you for being with us for this wonderful conference. And with this, we have ended this conference, that too before time. So thank you all the speakers and the chairpersons and the moderators for wonderfully chairing and moderating the session. And thank you all the organizing team. Thank you once again.
Along with this at the back. Not the... Just so that I know, I have it in my record. It's okay, thank you. Thank you.
ये यहाँ पे ना एक वो लगाना चाहिए था शिट नहीं मैं फेसबुक पे हूँ ही नहीं हूँ मतलब अरे मतलब हूँ लेकिन वो उस पर एक्टिव नहीं रहती हूँ कंचन मैं उनको बोलती हूँ कि वहाँ से ऑन करें यहाँ पे भी एक आ जाए
contesting an election. Thank you, ma'am.